So if y'all were sick of hearing my voice drone on for hours for the last few months, then this is the last time you got to get tortured with that. But you know, kind of sucks we didn't get. I was hoping to get this done before we got into Christmas, but it just kind of the nonstop 2020 hurricanes kind of kept pushing us back. But like I said, this is it. This is the end of your lectures. We're going to end it with geriatrics, and then you guys will get a small break between now and your respective boot camps. Those of you that are going to be at Pascagoula and the Beta Springs, your boot camps will be the 11th or the 15th. You guys are first at bat, followed by the Alexandria group. You guys will be the next week, that Monday through Friday. I think it's like the 18th through the 22nd. So if you weren't sure on what your dates were, it does depend on where you're going, but that's going to be it. And then I think I have a couple of people after that I need to take care of just based on your work schedules and where you're at. But those will be the main boot camps. And then after that, you move into your 48 hours of clinical ride times with the ambulance before you take your test. So I want to take this opportunity, and I'm recording this, so those of you that aren't here tonight, you can watch this as well. If you haven't paid your full tuition, it's way past time to get that caught up. We're getting to the point where we can't submit your stuff to the registry until you're paid up. So if you can't do that, that's okay. If you need more time, we'll just hold your paperwork. But I just want you to understand that you can't finish the course until you get that taken care of. I don't want you to fall behind. I don't want you to think you can't do your ride-alongs. You can do everything up to the point of going and doing your final testing. If you haven't been paid up by that point, then we'll just hold your paperwork back. Not a big deal. The times for the boot camp, I want to say they start at 8 a.m. It may be 9 o'clock. I got to look at the schedule, but it'll be business hours for the most part. And then when we're done for the day around 4:30 or 5 or whatever time it ends, you guys are free to do whatever. If you are turning these into little vacations, say some of you guys that live up in North Mississippi or Arkansas or something like that, and you want to go down and spend a week around New Orleans, this is a good way to do it. You're going to have your evenings and nights to yourselves, so you can do whatever you want. But anyway, let's get to it. This chapter is, thankfully, it's not nearly as brutally long as pediatrics was, but it is still pretty lengthy. So we're going to try to, there's a lot of this stuff that I am going to skim over, things that we've already talked about, things that I don't feel like we need to really beat to death, just because it's not that, a lot of it you should know by now. Like, for example, when we get to the point of your assessment, I'm not going to go over your scene size up, your primary, all that. You should know that by now. I'm just going to talk about the things that you're going to want to pay attention to if it's a geriatric patient, and then we're going to move on. So, like I said, make sure if you don't have your assessment memorized, get those sheets, the checklists, look at them, get it to where you can recite it. They're just one page each. And then when you show up to boot camp, we don't have to try to teach you something that you should have already gotten through the course of the lectures. And then we can just start actually putting them into practice. Boot camp is still an instructional atmosphere. It's not an assessment. So don't show up thinking you're getting tested. You're not. You're still learning. But there are some things that it would make it a lot easier if you show up with it already in your head, which is mainly the assessments and how they're laid out. So know what your team size up is, know your primary, your secondary, your ongoing, all that stuff. If you know what those are, then when we get to the teaching portions of the boot camp, it's all going to start to click and make sense. If you're still trying to catch that and learn that, you're going to be behind the curve. And we only have 5 days. So it will move pretty quick. It'll be over before you know it. Let me get to the right slide to start with. All right, so keeping with our special populations module, we started off, we talked about childbirth and OB, and then we went into pediatrics. Now we're in geriatrics. We're basically talking about everything other than adults, which is what you've been learning on this entire time. So we're going to finish this up with the end stage of life population that you're going to deal with. Geriatrics are considered to be anybody over 65 years. So think about the normal populations at this age and above, and what they've been through in life, how long they've been independent, how long it's been since they were kids. when you go through the majority of your life, you really don't want to give up that independence and that freedom that you've had for so long, right? Um, you also start to have a lot more like chronic issues, a lot more lifelong diseases and illnesses, ailments, things like that that you're dealing with. So a lot of your geriatric patients aren't not going to be very happy to see you. It's going to almost be like dealing with children all over again, but just for a different reason. The kids don't want to see you because it's all stranger danger thing. Elderly don't want to see you because they think that they had to call 911, therefore they're going to wind up in a nursing home or something like that. You have to deal with and dispel those fears, as well as treat your patient. And also keep in mind, sometimes your patient's going to be hard to treat because you're going to get there and you're going to find out that the reason they called you is part of a bigger issue that might be killing them. Nobody lives forever. We kick the can down the road as best we can, but at some point, that's just it. Um, so we're going to talk about that end of life section toward the end of tonight, um, and just go from there. So the baby boomer generation, that is our current elderly. They were born between 46 and 64, and they're a huge portion of the population. It makes sense. That's why their generation is called what it is. So no matter where you go to work, whether you take this and go work in a nursing home or any kind of extended stay facility, or as an ambulance, EMT, even as a fire department, you're going to run into a lot of elderly. So even though this chapter is not really that long, or at least that in depth, and we saved this till the end, this time of year, especially when you go to do your ride-alongs, you're probably going to deal with a lot of elderly. All right, so they put an age on this, 65 and above, but really and truly, how old somebody is physically just has a couple of things that play into it. So genetics. I know people younger than me have a head full of gray hair now. People younger than me have lifelong illnesses already starting to pop up, hypertension, that kind of thing. Lifestyle plays a big part of it, and sometimes it is your attitude. A good friend of mine says growing up is mandatory, but growing old is optional. Or no, I'm sorry, that's backwards. Growing old is optional. Growing up is God, I can't even say it. I screwed it up. Anyway, a lot of it's in your head. You typically once you start to slow down and stop living, that's when your age catches up to you. Anyway, geriatric patients present as a special challenge for healthcare providers because the classic presentation of injuries and illnesses are sometimes altered or even hidden by chronic conditions, multiple medications, and the physiology of aging. Remember, we talked about beta blockers, for example. It's really hard to get an idea of what's going on with somebody based on vital signs when they're taking medication that affects those vital signs. Beta blockers stop you from getting a high heart rate. So if you have a trauma patient that is trying to compensate for shock, for example, and that big compensation mechanism is going to be a higher heart rate or higher blood pressure, but they're taking blood pressure medication and a beta blocker, they're basically medicinally hindering themselves from compensating, and they're going to start to decomp that much faster. And now you've got somebody that's going unconscious on you a lot faster than you would have hoped for or expected, depending on what the call was. The big thing, though, like I was saying, these are people who have lived their entire lives, the bulk of it sometimes before a lot of us were even born. Um, they've definitely earned their respect, earned your respect. So make sure that you treat them with that. A lot of times, if you show up and you're talking to them like you would talk to a 17-year-old, they're going to shut down on you and not want to listen to you because you've pretty much offended them. So make sure you maintain their dignity, maintain their respect, give them that respect. If you're not used to sir and ma'am, this is a good time to do it. Just because a lot of times these individuals were raised where that was common. I know that, like where I live in the country right now, I get weird looks when I say sir and ma'am sometimes. So they think I'm being offensive, but older population, military, especially if you have elderly veterans, say like Vietnam vets, that's huge to them. So it says here in the slide, make every attempt to avoid ageism. It's basically like racism, but you're segregating them out from normal based on their age, not their race. It's pretty much the same thing. But basically, just don't show up thinking that every old person is hard of hearing, right? You don't want to walk into somebody's house and start shouting at them because you assumed they were hard of hearing. and they can hear just fine. Not all people have dementia or Alzheimer's. Not everybody gets that stuff. My grandfather's pushing 80, and he can hear fine. He has no mental illnesses, nothing other than some gray hair and some bald patches would tell you that he was that old. Granted, the last couple of years he's been starting to slow down, but he still works. And he works in a warehouse at that. Not all older people are sedentary or immobile, and older people can stay fit, be active. In fact, here's an interesting one. So when I moved back to Louisiana a couple of years back, I worked at a fitness club in Slidell, and I just, as a little part-time job, just for extra money, and I worked at the front door. This guy walks in at like 8:30 one night, and he comes in, he's moving quick, he's got muscle definition, and his bag's thrown over his shoulder and everything, and he signs in, and I look at his birthday, and it says he was born in the 30s. I thought they messed his birthday up. I asked him, and he said no, he was like 84 years old, 84, 85 years old, and the guy looked like he was in his 40s, and he acted like it too. He went into the gym, lifted weights, got on the treadmill, ran, came back out dripping sweat, and I swear to God, you're half your age, man. So don't make sure you don't get those preconceptions and prejudices going when they shouldn't be. Effective verbal communication skills are essential to successful assessment and treatment of older patients. So um, know that for statistics, that guy was definitely an outlier. But statistically, as we age, they're gonna get changes in vision, hearing, taste, smell. Pretty much all of their senses are gonna start to kind of dull out. In some cases, they may get a little bit more. I'm not going to say more sharp, but more like fine tuned. For example, some elderly can't eat spicy foods. It's easy to get too hot, too much spice, that kind of thing. Something too salty, they might notice it more. Changes in communication abilities, accompany aging, such as dementia and other diseases. So you will see that, but like I said, just don't assume that everybody's got it. The first words to your patient and the attitude behind them can gain or lose a patient's trust, and a lot of times they will have everything decided about you the minute you walk in the door. The the way you walk in, the air about you, the things you say right off the bat. By the time you get to doing your ABCs, if they're going to trust you, they're going to trust you by that point. If not, you've already lost them. So um, keep that in mind. Now, some patients they may not be in their right mind, so come with me with that. That's a little bit different of a story. But if it's somebody that just for whatever reason, say they missed too many dialysis appointments or something, they're in the right mind, but they're just not. They're having an issue, or it's traumatic in nature, or something of that sort. Then you want to make sure that you just don't go in with the wrong mindset. If you know the patient's last name, you can use Mr., Miss, Mrs., whatever. Um, I like to ask them what they would like to be called. I default to, Mr. Jones or Mrs. So and so, just because it's a respect thing. But if they are like, call me John, then so be it, and I'll use their name. Um, just be careful with that. Again, use what they prefer as a sign of respect for them. Some people, I've gone to before they said I used their military rank, despite the fact they retired like 40 years ago. It was just they wanted to be called Sergeant so and so because that's what they were in the military. Um, when you interview an older patient, the following techniques should be used. So let me get to the right slide here. Did I go too far? Yep. Okay, here we go. Identify yourself. Walk in, and when you do this in the real world, you're going to wind up doing this all the time for any age. You walk in the door, extend your hand, say, "Hi, my name is Rob. I'm going to be your EMT today. Can you tell me what's going on?" First of all, you identified yourself. And depending on, as long as they can answer you, you pretty much just knocked out your primary assessment right then and there because they were able to take a breath to give you words back. They gave you answers that were legit, accurate to what you asked. Hopefully, they reached up and shook your hand, so you felt some strength in their grip when you shook hands. So you've got that motor function and everything. And just in your introduction, you've pretty much knocked out everything on this slide as well as your primary assessment. Granted, like I said, in school, I don't want you to do that. Well, you can do it, but I want you to tell me what you're assessing when you do it. When you go to the real world, you're not going to say your assessment out loud. That stuff's just running in your head, but you'll get better at that as we go. That's one of the things we'll do at boot camp. Look directly at the patient at eye level and ensure good lighting. Make sure they can see you clearly. And remember, if the light's behind you, think about what that does. It silhouettes you. It makes it hard to see your facial features. Try to place yourself where the light shines on you from the front so that your patient can clearly see your face. A lot of times that will help as well. Have one person talk to the patient and ask only one question at a time. Let them answer thoughtfully before you move on to the next question. Don't assume that all older patients are hard of hearing, and keep in mind too, a lot of times when patients become hard of hearing, it's not the volume that they have a problem with, it's the pitch. Um, a really good friend of mine's grandfather is hard of hearing, and his family's always shouting at him, and you can see him just kind of wincing back because they insist on shouting. They think that, because he's wearing a hearing aid and stuff like that, that it's a volume issue. That's not always the case. A lot of times your hearing is lost in ranges. So if your patient's having a hard time hearing you, try lowering your voice as far as pitch goes. So get a deeper tone. And, as an example, when I talk to them, I lower my voice just a tad. I don't have to do it very much because I already have a deep voice, but um, he hears me just fine. I can have a normal volume conversation with him and he catches everything. And then his daughter and granddaughter and all of them, they're all shouting at him because they have a higher vocal range, and they don't, even though I've said it, I was like, try lowering your voice. They, they're stuck on volume. Um, if you're not sure, you can, and if you show up to somebody's house and the wife tells you that the husband's hard of hearing, you can ask, be like, is it pitch or volume? And depending, like, do I need to speak up or do I need to lower my voice? A lot of times they'll know that because the doctor will have told them, or they failed a hearing test. A lot of times in the military, our problem is ranges. That's why when we take our hearing test, you're hearing a little press a button every time you hear a beep. What's happening is it's gauging your hearing range based on pitches. How high of a note can you hear? Um, a lot of times that's what your hearing loss actually is. It's not the volume. Speak slow and distinct, just in case, right? Don't speed through, especially if it's a cardiac call. The more amped up you are, the more amped up your patient's going to be. And if it's chest pain or something that might lead you down the cardiac route, if it is cardiac, um, you can make the situation worse. Explain what you're going to do before you do it, and don't talk to the patient in front of him or her as though the patient's not there. So if you're talking to the wife or the husband or whatever, still direct your questions at the patient, just like with a child that's a teenager or something like that. Yeah, the spouse may have to answer. That's all right, though, just for the sake of independence and recognizing that that person is able to make their own decisions and would hopefully be able to answer your questions. It goes a long way to directing the question. And if all you do is you just sit there and glance at the guy or girl and you talk to the spouse like they're not there, they're not going to want to cooperate with you. Listen for your answers and explain what you're going to do before you do it, even if they're unconscious. We talked about that before. Some common complaints and leading causes of death in older people. Simple rib fractures in an 80 to 90-year-old person can result in pneumonia or even death, especially if it ruptures a lung or something of that sort. Not to mention, think about the mechanism of injury for hitting a rib. If it's bad enough to break a rib, which for an elderly person is not the same amount of force it would take to break a younger person's rib, their bones are much more brittle. That damage can still transfer through and hit the lung. A hip fracture from a low mechanism fall, even just from standing up, is common. Think of it kind of like when we talked about pregnancies, how they're more susceptible to falls. Even just from a standing position, an elderly person can fall, and because their bones are more brittle, that's actually one of the biggest concerns and leading causes of death in old people, because they will have profuse internal bleeding. The body can't recover as fast, and then they wind up dying from that. Sedentary behavior while healing can predispose a patient to pneumonia and blood clots, mainly blood clots. We see this a lot in patients who can't, they're bedridden, for example, and they don't get rolled. So extended care facilities. Um, Not going to name any names. I'm not really thinking about any in particular, but because it happens everywhere. Um, if the CNAs or the nurses or whoever, if they fail to roll patients properly, um, then the bed sores kick in, the clots can kick in, and those can be life threats. So the most common conditions in geriatric patients are hypertension, arthritis of any type, heart disease, cancer, diabetes, asthma, chronic bronchitis or emphysema, and a stroke. The leading causes of death in the geriatric population include heart disease, cancer. A lot of these are the same. Chronic low respiratory disease, so deep tissue, deep lung, pneumonia type stuff. It's not uncommon when you're listening to breath sounds on an elderly patient, you're going to hear some rails, some crackles in the lungs, in the lower lungs or whatever. That is sometimes that's just chronic for them. So if we give you an assessment and I tell you that you hear some of that in the lower lungs, I don't want you to freak. I just want you to note it and remember that if there's fluid there, there's always that chance that it could get up into the airway, and we want to be able to suction that if it happens. So if I tell you that you're listening to lung sounds, your upper lungs are clear, your airway is clear, but your lower lungs have some fluid in them, um, there's no intervention for that for you. What I would concern you, or what I would want you to be concerned about is where did that fluid come from? Am I dealing with congestive heart failure? Because that's something that could affect the airway, right? In which case you would then do something about that, either suction or use your BVM to provide some positive pressure or whatever. If you're dealing with somebody that just like sprained their ankle or fell and you're listening to lung sounds and you hear fluid in the lungs, in the lower lungs particularly, which is way away from the upper airway, um, sometimes that's normal. So just keep that in mind. All right, I don't want you to latch onto it every time when you're dealing with a geriatric patient, but it's definitely worth noting. And just keep in mind that just because it's not a primary thing for you to fix doesn't mean that you may not have a harder time keeping their O2 sats up, because where that fluid is, there's no gas exchange. Anyway, moving back on. Stroke is leading cause of death, Alzheimer's disease, diabetes, and influenza or pneumonia, especially in these kind of months where they don't want to get out. Flu's already going around this time of year. It just happens. People get sick. Human growth and development peaks in the late 20s and early 30s, and after that, it is all downhill. So the process of aging is gradual, starts much earlier than most people realize. I know I couldn't stand being told I was in my prime when I was a teenager because I didn't understand at the time, but being 38, I definitely get it now. Even today's workout kind of kicked my ass. The aging process can vary dramatically from one person to another. So again, I'm 38. I have some gray hairs, but mostly all my hair is still there and it's brown for the most part. But some people I went to school with, their facial hair is silver. Um, they may be bald. Some of them are bald now. They just, skin's already starting to wrinkle. They look like they're 10 years older than me. And some that have some particular extracurricular activities that they like to do have sped that aging process up even more. All tissues in the body undergo aging. Basically, your cells are dividing. When you're growing, they're creating new cells faster than the old cells are dying. As we get older, that process reverses. Um, so some cells are going to die off faster than they get replaced, and then that's when we really start to show our age. Don't mistake the changes for signs of illness, and give treatment when none is necessary. Again, going back to the lung issue, just because you might hear some lower sound, some crackles or rails in the lower lungs, doesn't mean you actually have to do anything. As long as it's not affecting their airway and you can keep their O2 sats good, then that's all you got to do. Genuine symptoms should not be attributed to just getting old. If they have something wrong with them, um, then don't just write that off as being age related. But if it's just like a random symptom that doesn't apply to anything that's going on, note it and don't worry about it. All right, so the next couple of sections that we're going to go over are changes to the different body systems. So we're going to start with the respiratory system. Age-related changes can predispose an older patient to respiratory illness. One of the biggest things is that their breathing capacity is going to drop. Their lungs are going to become a little bit less. The alveoli will start to age, especially if they're smokers, anything that would cause emphysema. A lot of your patients, you're going to find if they have emphysema, typically it hits in the older stages. Um, Also, the chest wall, because the ribs get more brittle, the chest wall starts having a harder time rising, so their breathing is going to get more shallow. And so, if there's anything wrong, if anything happens, they're already kind of behind the curve. Now, our respiratory system as we get older is not as much of a life threat as it is if we're kids. So, I don't want you to, you know, let the end all be all of your treatment be respiratory. However, yes, it will, you're going to notice it does start to have problems a little bit sooner in big issues than it would be if it was a healthy adult. That's why, like coronavirus, for an example, um, tends to take out a lot of the elderly. It's because their respiratory system is already weakened with age. That cytokine storm hits after the virus clears out, and then they just don't recover from it. Um, It's not just an age thing. Younger people, there was a guy 4 years younger than me that died from coronavirus recently. But yeah, just keep that in mind. They are at a much higher risk. The alveoli and the lung tissue can become enlarged and the elasticity decreases, which makes it harder to expel used air. Um, Remember, like we talked about, was emphysema. That's basically what that's getting at. And the body's chemoreceptors will slow down with age. Pneumonia. Patients have a high risk of pneumonia as they get older. Some of them will carry pneumonia as a chronic illness, which means that, like I said, you listen to their lungs, you hear a little bit of diminished lung sounds because there might be something there. They just have pneumonia. They've had it for months, years, whatever. It doesn't go away. Um, this is a chronic lower respiratory disease. Influenza and pneumonia are in the top 5 causes of geriatric deaths. Pneumonia is an inflammation or an infection of the lung from bacterial, viral, or fungal causes. It is the leading cause of death in Americans older than 65, even up there with heart disease. Just as an age group, this is a leading killer. So this will produce an increased amount of mucus, pulmonary secretions, and the inflammatory effects will start to kind of clog up in the alveoli around the lower lungs, and it interferes with the ability to have that gas exchange. That's the problem with it. If you're listening for breath sounds, you can actually tell where the pneumonia is at because you'll hear clear breath sounds all over the place, but there'll be like one section of the lung where when you listen, it's kind of diminished out. It's kind of hard to hear. So remember to wear respiratory protection when assessing a patient that might have pneumonia, because if it's bacterial, um, it can definitely become contagious. All right, I talked about that. Pulmonary embolisms. This is a condition that causes a sudden blockage of an artery by a venous clot. The older we get, the more likely we are to throw a clot. If it winds up going up a vein, it'll wind up in the lungs, and then they're going to have the embolism and make it hard to breathe because their blood flow is not moving like it should be. The air is getting into the lungs, but the blood's not there to make the gas exchange. So their ventilation is there, but their respirations are not. A patient with a pulmonary embolism will present with shortness of breath and sometimes chest pain as those muscles start to, especially the heart, starts to get hypoxic. You're going to start to feel some pain there. This can be confused with a heart attack or a musculoskeletal problem. Just look at your risk factors, look at your symptoms, that kind of thing, and you'll be able to kind of narrow it down. We don't have to diagnose this in the field. Luckily, our treatment at the EMT level is pretty much the same. So even if you're wrong on your assessment, as long as you're doing the right treatment, that's all that matters. Some risk factors for pulmonary embolisms: living in a nursing home or recent hospitalization, so recent surgery. If they are bedridden, they have a high risk of this because they can get those thrombuses to form in their veins because they're not being rolled over. So blood gets stagnant, it clots. Then they do move. Suddenly the vein opens back up and those clots start moving. Trauma, cancer can cause this. If they have a history of blood clots or heart failure, a certain heart arrhythmia called atrial fibrillation is a really big common cause for this. That's where the atria just fibrillates. The ventricles are beating fine, so they're getting blood flow, but the atria don't beat normally. They just kind of quiver. What that does is it causes the blood to kind of pool up in the atria. It doesn't get pushed through like it should, and anytime blood stops moving, it can form a clot. So if it's in the right atrium where it's getting clogged up, or where the clot happens, and it finally gets pushed into the right ventricle, it's going to shoot off to the lung, and then they're going to have the pulmonary embolism. If it happens on the left side, then they're at more risk of a stroke, right? Because that's going to go out to the body, and if it winds up going north rather than south, it's going to wind up going to the head and clogging up arteries there. Uh, Presence of a pacemaker or a central venous catheter can cause this. Paralyzed extremities, again, for the same reason as being bedridden. Obesity can do this. Extreme obesity, not just a little couple pounds overweight. Recent long distance travel. The longer you sit in a car seat driving, or even as a passenger, if you don't get up and walk around, the same clotting issue can happen. A lot of this is just, if you notice, it's just any position where you don't move for a while. Sedentary behavior. And then if this happens, your patients are going to have a fast heart rate because your heart's trying to pick up the pace. It can't figure out why it's not getting the blood flow, so it's trying to beat harder and faster. Sudden onset of dyspnea, shoulder, back, or chest pain, cough, syncope, which is a fainting episode, anxiety, apprehension with a low-grade fever, hemoptysis, leg pain, redness, unilateral pedal edema. In other words, you're just going to have swelling in both feet, equal across. If it's one side or the other, then a lot of times you're winding up with that's going to be a problem in the legs, and the blood's just getting stuck on one side. Fatigue, cardiac arrest, which is a worst case scenario. Hopefully that's not what you see, but sometimes that is the case. Sorry, I have not been clicking slides. And then treatment should focus on the airway, ventilation, and circulatory support. If this is what you're dealing with, then we need to be really hammering down on their respiratory system to try to get going what we need to. Even though this is a cardiac issue in a sense, because it's in their vessels, we're not surgeons. We can't go in and grab the clot. We don't have clot busters in the field, that kind of thing. So we stick to what we can do, which is basically overloading with oxygen. Whatever blood can get to the lungs, we want to make sure it gets as much oxygen as it can, and it carries it around to the body. Even if it's hindered, we can, again, kick that can further down the road until we can get them to the hospital, and then the surgeon can take care of them, hopefully. But supplemental oxygen is mandatory. This is one where I don't want you to worry about 94 to 99. If they have a pulmonary embolism, just flood them with oxygen. Give them 15 liters non-rebreather. Changes in your cardiac system. So there's a couple things that can change here, be it between the vessels, the heart itself, all that stuff. The heart will hypertrophy. Think of it just like going to the gym, right? You get a guy that goes to the gym all the time, his muscles get big, they get a little bit tougher, a little bit harder to move. You squeeze somebody's muscle, whatever, it's a lot more rock solid, that kind of thing. The heart's going to do the same thing. After 60 years of beating, and it's a muscle, or 70 years of beating or whatever, some parts of the heart are going to start to do just what any other muscle would do. It's going to get bigger. And as the heart gets larger, the chambers are going to get smaller because that space is going to be taken up, which means that the chambers are going to hold less blood with every beat. And so they're going to get less blood flow, less stroke volume, that kind of thing. So the cardiac output's going to decline, and it's mostly because of a decrease in their stroke volume. Arteriosclerosis, which is a disease that causes the arteries to thicken, harden, and calcify. This helps lead to hypertension, especially when those vessels start to really kind of close off. Some changes in cardiovascular performance are probably not directly due to aging, but rather as other things. So for example, what this is saying is it's not because they're 70 years old, it's because they're not exercising as much. Their age is stopping something else, and that's causing the hypertension. Usually, it's because they just kind of stop working out as much, unless you're like that one guy that completely blew my mind. Your geriatric patients are definitely at risk for atherosclerosis, especially if they've had a crap diet. So keep that in mind too. This is where if you lived a steady diet of bacon and sausage your entire life, you've clogged up your arteries a bit. Sometimes it happens just in general. We always keep a little bit of cholesterol in us, and even if we've eaten pretty healthy most of our lives, we're still at risk of this. Over 60% of people in the geriatric range have this to some extent. It may not be a complete blockage, but it's going to be enough to really kind of slow things down. And the problem here is that all of this thickening, all these calcifications have the risk of breaking off and becoming clots that can get stuck in the lungs, get stuck in the head, that kind of thing. So you're running the risk of an embolism or a stroke. Older people are also at an increased risk for formation of an aneurysm. We talked about aortic aneurysms. They can have an aneurysm anywhere. Doesn't have to be the aorta. Any vessel can cause this. This is if it pops, you're going to have severe blood loss, especially if it's in the aorta. If it's in the brain, it may not be severe blood loss, but it could be bad for that area, right? We already know that there's pressure in the head, and it's supposed to stay at a certain rate. If you start losing blood up there, that's extra pressure, extra things in the same enclosed space. So it may not be blood loss on the point where you're dying of that, but the amount of blood that's loose in that area could be the problem. Other anatomic changes include stiffening and degeneration of the heart valves. So the valves themselves can develop stenosis, which may impede normal blood flow in and out of the heart. The valves may not open all the way, which can restrict blood getting into certain chambers. The valves may not close all the way, which could cause backflow. Um, the heart's going to have to beat harder to push blood past a stiffening valve, which means your heart's going to kind of wear out faster. You could have circulation issues due to it. Blood pressure can climb due to it. All this stuff. So these are things that can happen as you get older, and genetics will play a lot of part in that. That's why we ask them, make sure you ask your family history. Anybody else in your family have heart disease or heart attack, particularly like say before 50 or before 60, that sort of thing. Aging can also alter the heart's electrical conduction system, so you're much more at risk to find things like heart blocks. And I know that we didn't really talk about those in this class because they're a little out of the scope for EMT. I do recommend once you get past EMT, learn the heart blocks, learn some cardiology because it'll make you better. I just don't want to screw you up for registry, so I don't want to get into it here. Just because anything to do with it is going to be out of your scope, and you need a monitor to find it. So that's another reason. Orthostatic hypotension, is that on this slide? It is not. Maybe it was. Okay, so you just don't have it on here. All right. Anyway, orthostatic hypotension is a drop in blood pressure with a change in position. So if you've got somebody laying on the recliner watching Jeopardy, and they get up to go to the bathroom and they get up too quick, their body's not going to adjust to the change in gravity very well, and they may get lightheaded and pass out. This is not necessarily vagal nerve stimulation, but it'll operate like that. They'll knock themselves out, hit the ground, the body regulates, and they wake up. And then with that comes the whole, did you break your hip? Chances, those kind of chances. Another vessel-related problem is called venous stasis. This refers to the loss of proper function of the veins in the legs that would normally carry blood back to the heart. If they can't push properly, be it that they've stiffened up, that kind of thing, then the blood goes down in the legs, but it can't get back up to the heart. This will cause blood flow issues, which could lead to stroke, can make them hypoxic, causing blood clots, all kinds of stuff of that sort. Deep vein thrombosis, if you've ever heard of that, DVTs, these can lead to pulmonary embolism because, again, if a clot breaks off in the veins, where's it going to go? As it goes closer to the heart, the pipes are getting bigger, so it's not going to get stuck anywhere before the heart. And the first place things go first place blood goes after getting to the heart is to the lungs to get more oxygen, and that's where things get constricted. So if there's a clot there, it's going to get stuck in the lungs. People with DVT, and this is not even an age thing. A buddy of mine is in his 20s and he has DVT. But people with this condition usually exhibit edema or swelling of the legs. It'll hurt. It'll get inflamed and red. A lot of times that is because there's a clot that is stuck somewhere and is hindering blood flow. Getting up and moving around will sometimes break the clot free, but now you got a clot floating around in your system. So this is still a very dangerous thing. Heart attacks, we talked about this at great length in cardiology, so I'm not really going to beat this to death. Just know that your patients are at a high risk for this, and different patients will present differently. In other words, when you hear about if a guy tells you that they have, it feels like a tightness in the chest and that feeling of impending doom that we always talk about, and oh, it hurts going down my right arm, or I'm sorry, my left arm, all that kind of stuff. Those are signs of a heart attack. If it's a woman, they're probably not going to tell you those signs. A heart attack will present more with like an indigestion kind of feeling. They're going to tell you they have epigastric pain. Um, Females' heart attack symptoms tend to be more centralized and a little bit lower. So they think that they will tell you that it feels like they have some pain above the stomach. Um, and a lot of times what they're telling you will make you start to wonder if it's heartburn more than heart attack. So just be aware of that. Women do present differently. Um, if you ever hear epigastric pain from a woman, I want you to think heart attack. Better safe than sorry. It could be heartburn. Maybe she had some bad chili, but rather take her to the hospital and get some Tums than not take her to the hospital and she die on you. Okay. Heart failure. This is much worse than a heart attack. Remember, your heart attack is just where a part of the muscle dies. Heart failure is where the whole heart stops working. So signs and symptoms will differ depending on the extent to which the right and left side of the heart are not functioning correctly. If it's just the right side, usually the problem winds up being that their blood pressure is more unstable. The left side's working, so it's getting blood places, but the right side is not being able to feed it very well. Also, with right-sided failure, you're going to see some things. It's like jugular vein distension. Remember when we were doing our head to toe and we checked the neck? Those things that we're checking, like tracheal deviation for the lungs, JVD on the sides. We're checking when we check for JVD is to make sure there's no blood being backed up. If the right side of the heart fails, the blood won't be able to get pushed past it. So the failed side of the heart, everything prior to it, is going to fill up with blood, and that's the vein side. So the jugular veins are the easiest ones to see that swelling in. That's why we look. All your veins are going to be distended, that are kind of close to the heart, but the jugular veins are right there on the side of your neck, and when they engorge, you can tell. You can see it. An enlarged liver may also be present. We can't detect that in the field, but you may be able to feel it when you press. So remember, the liver is on the upper left quadrant. If you press and it's inflamed or enlarged, you're going to feel it's going to feel like a mass is right there. Right-sided heart failure is often caused by left-sided, especially if it's a hypertrophy issue or a cardiomegaly, because those muscles have built up over the years. If the left side fails first, the right side is now beating against a wall, and it's going to wear itself out. Sometimes, though, the right side is the side that fails. You just have to be careful because it's not always. But those are the dangerous ones. The right side, if that's what's failed, and you give your patient nitros, you run the risk of really crashing their blood pressure, even though they might have had a good blood pressure. Remember, we have to check that, make sure they're over 100. If it's right-sided heart failure, they could have 120, 130, whatever, and they'll still crash. But again, it's not the most common. There's no way we can tell that without a 12 lead. So when in doubt, if everything matches the way you know how, you can give the nitros with permission. Just be aware of that. If you give them nitro, they had a blood pressure of 120, and then suddenly they crash on you. that can pretty much tell you right there they had right-sided failure. With left-sided failure, the fluid backs up into the lungs because, again, the problem, the lungs are what are feeding into the left side because now it's got to go out to the body. So if the problem is on the left side of the heart, the blood backing up from the entrance to the left side is going to back up toward the lungs. This can cause pulmonary edema. Your patients will start to drown in dry air. Your congestive heart failure symptoms are going to show up. So you're not so much concerned about blood pressure and that sort of thing. Now you're concerned about keeping their airway clear, keeping their lungs clear so that they can breathe. So those are the patients, if they're having left-sided heart failure, those are the patients that you're going to wind up bagging to try to keep their lungs clear. So use that positive pressure. If you can use CPAP, if they're awake and you have it in your system, you can use CPAP. Hospitals like to use BiPAP. If all else fails, just grab the BVM, and if they're somewhat awake, tell them to breathe out against your bagging. If they're unconscious, then just bag them. It's the best you can do. Like that's right-sided, that's left-sided. And then this is one that I want to point out to you because a lot of times your patients are going to have this. You're going to get those 1 a.m. calls. Paroxysmal nocturnal dyspnea is a condition that is characterized by a sudden attack of respiratory distress that wakes the person up at night when they're reclining. So paroxysmal means that it has a definite start. Nocturnal being, nighttime when they're asleep, and dyspnea being a trouble breathing. This is caused by fluid accumulation in the lungs, typically happens when they lay down. They'll report coughing, feeling like they're suffocating, and cold sweats. You'll notice that their heart is beating fast, so tachycardia. And if you suspect congestive heart failure, which is the extreme end of this, one of the questions you can ask is, do you sleep sitting up? I did that for a while because of my heartburn. Sometimes it helps. And a lot of times when your patient sits up, their symptoms will start to clear up because now they're in a different position. If they are in full-blown CHF, though, sitting up may not help it. But that's a way that you can kind of tell whether they're having a full-blown heart attack or if it's something like this is when you sit up or stand up, does it get any better? Does it change when you change position? It may not get completely better, but if it improves, that lets you know that it's probably not the heart. It's probably something along the lines of the blood flow or a clot or, something of that sort. It can help narrow down what's going on with your patient. Stroke, leading cause of death in older people. I think we had an entire chapter on this. So just remember, if it's a arterial bleed or a blockage, a lot of times they're going to feel a lot of pain from that, and it's going to happen fast. If it's a venous bleed, those are slower. And then depending on where the blockage is, you may have some issues. If it's if it's on the left side of the brain, it's going to affect the right side of the body. However, it will affect the left side of the face. The face is equal to the side of the brain. So left brain, left face, right brain, right face. The actual swap happens at the base of the skull. That's where it becomes, left brain, right body. Some signs and symptoms: acute altered level of consciousness, numbness, weakness, or paralysis on one side of the body, slurred speech, difficulty speaking. If it's in the Broca's region, you're going to have difficulty speaking or difficulty understanding. Visual disturbances, headache and dizziness, incontinence, and seizure. Not all seizures come with incontinence. That's not a sign that people are faking. Paramedics say that. They usually say that for the benefit of the patient hearing them in case they are faking, but don't take that as law. Hemorrhagic strokes, this is where they're actually bleeding out. So depending on where they're bleeding, this could be a slow onset, a fast onset, but it's not really common unless there's trauma involved. So if they're sitting in their chair, it's probably not hemorrhagic stroke. It's going to be more likely it's going to be a clot. Ischemic strokes occur when a blood clot blocks the flow of blood to a portion of the brain. That's your most common stroke. But just like any other, you want to, figure out when they were last normal, get them to the hospital as quick as you can because time's not on your side, and give them a lot of oxygen. Make sure you can get as much oxygen to their brain as you can. treatment goals, salvage much, yeah. So remember, TIAs, transient ischemic attacks, they're like temporary strokes. So if their symptoms are gone within 24 hours, then it wasn't a full-blown stroke. However, something had to cause that. Usually it's a clot that winds up getting broken free and moving on. If that happens, that clot, it may still be floating around up there. They could wind up having another blockage. So just because their symptoms cleared up doesn't mean you don't want to take them to the hospital. Let them know that. Be like, look, this happened for some reason. The only thing that would just disappear is not a brain bleed. It's going to be a clot that broke up into smaller pieces and it was able to start moving again. If it gets into smaller vessels and blocks off again, then they're going to wind up with another stroke, and it could be much more dangerous depending on where it's at. So try to talk your patients into going to the hospital. If it's a TIA and they're not presenting with symptoms when you get there, they don't necessarily have to ride with you, but they should go and get a CT scan, see if they can see those clots anywhere up there and get them out. Changes in the nervous system. I don't know if you guys remember when we talked about the nervous system. Remember, your neurons don't regenerate. If you lose a nerve or a neuron, it's gone. That's it. What you have is what you have. So changing in thinking speed, memory, and posture stability are the most common normal findings in older people. But notice that it doesn't say intelligence. All right, you don't get dumber as you get older, so don't make that mistake. Just because somebody's elderly doesn't mean they don't know what they used to know. They might have forgotten some things, but they're definitely not dumber. It's not like you lose your intellect. You may have just lost your memory of certain things because you haven't done it in a long time. When I'm 70 years old, I'm probably not going to remember half the stuff I know now, unless I just keep doing this until that point. The brain decreases in terms of weight and volume as a person ages, and with that means there's going to be a little bit more space between the edge of the brain and the skull. So in trauma, the brain has more room to move, which means they're at much greater risk of shearing blood vessels. So in trauma, they have a higher risk of having any kind of brain bleed, be it from a vein or an artery or whatever. That risk is just much higher. There's 5 to 50% less neurons in older people. And again, those don't come back. It's not like the liver. And the performance of most of the sense organs declines with increasing age. Your reflexes start to slow down. Your response times start to slow down. If somebody wrecks in front of you on the road and you're 65 years old, you're not going to respond as fast as if you were 25 or 30. You're probably getting closer to how you would have responded at 15, 16 when you were first learning how to drive. Visual acuity and depth perception will start to go as you get older. The ability to see at night will go. I know my grandmother always said she was a day driver only. She couldn't drive at night. When it got dark, she just couldn't see. Her night vision was not there at all. Cataracts can start to occur. This is a clouding of the lens, which makes it hard for light to get through. So it'll kind of mess up your color vision. It'll make it harder for you to see clearly. And if it does block light, then your vision will dim. So like if you're in a bright room, it may not appear bright to you because some of that light's getting refracted away. Decreases in tear production can lead to drier eyes. Inability to differentiate colors, like I said, less night vision. And a number of other diseases can plague vision in older adults, including glaucoma, macular degeneration, and retinal detachment. Hearing, I'm not going to beat this to death. We already talked about it. Like I said, just remember, not all hearing loss is volume related. Sometimes it's pitch. So if you change the tone of your voice to a lower tone, your patient may be able to hear you just fine. Usually we lose our hearing from the top ranges down. Taste can change as you get older. The negative result would be lessened interest in eating, which can lead to weight loss, malnutrition, or complaints of fatigue. The bones are getting brittle. If they start to have a calcium deficit in their diet, the bones will continue to become more brittle because the body needs calcium to make the heart beat. It needs calcium for muscles to work. The body's going to prioritize that over bones. So if they're not eating enough calcium or taking a calcium supplement or something of that sort, the body's going to take an already falling apart skeletal system and make it even worse because it needs that calcium somewhere else. For touch, an older person may have a decreased sense of touch and pain perception from the loss of end nerve fibers. Um, Mostly you're going to find this in their hands and feet. They may not be able to feel you as well, or they just may not feel extreme pain as easily. So they're more likely to burn themselves. The burns could be worse because between the dulled down sense of touch and the slower response time, their hand or their foot is going to be on the burning surface longer before they realize and they're able to move it. So you may find worse burns, for example. All right, we're going to take a 10-minute break here because now we're getting into some mental illnesses, and this one's going to take a bit. So we'll go ahead and take our 10-minute break now. It's 6:57. Be back at 5 after, and we'll continue on at 7:05. All right, let's get back to this. So, talking about some mental degradation that we have as we get older, we're going to start with dementia. Dementia is a slow onset. This is going to be the key point here because we're going to talk about delirium in a second and it gets a little different. Dementia is a slow onset of progressive disorientation, shortened attention span, and loss of cognitive function. Um, I've seen dementia patients where they just kind of like they'll walk toward a door, and instead of opening it and walking through it like you would think they would do, they just kind of stop and stare at it, and they'll just stay there. They can stay there for 30 minutes, hours, whatever. You forget why you walked in the room, which is kind of scary because I do that all the time. Um, you just kind of have that. You start searching for answers and you just can't find them. They're on the tip of your tongue, and it starts to after a while. It starts off. It's like I don't remember this technical thing, and then it becomes I don't remember um, how to make this like a food or something simpler. I don't remember how to drive a car. I don't remember how to do these things that progressively are easier and easier things over time, but you just start to lose that ability to do it. And yeah, no, me too. I'll forget. I had the realization the other day. I was getting upset too. I was getting kind of pissed off. I was looking all over for my phone, couldn't find it. And I didn't want to turn the light on in the room because my son was asleep. And I could not find my phone for the life of me. And it took me about 5 minutes to realize that the flashlight I was using to find my phone was my phone's flashlight. Um, I've struggled to find a pencil that was currently in my hand. I actually had that problem when I was like 16. So, and no, for the record, I've not done drugs. I don't know why I had that problem, but I've got some stories. I've put milk in the cabinet instead of the fridge, just not paying attention. Anyway, I digress. Dementia is a result of many neurologic diseases and may be caused by Alzheimer's, Parkinson's disease, cerebrovascular accidents, or genetic factors. So let's see. You're past four. I'm getting there. I'm getting there. I'm 38. It's coming fast. All right, we already mentioned that part. So determine your patient's normal mental status by questioning family members. Say, just ask them, is this normal? What if this isn't normal, then how long ago were they normal? Evaluate history, risk factors, and current medications. On assessment, the patient may exhibit a loss of cognitive function where they just seem like they're awake. They may be looking at you, their eyes are tracking you or whatever, but they're not there. It's the best way to put it. They like you walk up and you introduce yourself to them, and they just kind of stare at you like they're like you expect them to answer. You can tell that they've processed what you said, or at least they've received what you said, but something's just not happening in the brain, and there's no real response. That's kind of what you're seeing here. And again, this is a slow onset, long term thing. They also may show a decreased ability to communicate in general. They could appear confused. Some other aspects of dementia can complicate your ability to assess and manage the patient. If you're trying to do an assessment, you need them to answer a question for you, but they're just not understanding. And it's an OPQRST question, for example, where the only person that can give you that information is the patient themselves. You may have to kind of make your assumptions as though they were unconscious. So, if you're stuck between a rock and a hard place, err on the side of caution. Some patients are not only confused, but they may be angry because, and I've seen this a couple of times, they're not processing what you're saying, but they're aware enough to realize that they should be. And that's a scary place to be in. It's like this half lucid, half aware, I know something is wrong with me kind of thing. I just can't get past this block. Like you said something to me. And, they have enough self awareness to know that something's wrong. There's a disconnect in them and they can't fix it. And it really does it'll tick them off. They're not mad at you. It's just extreme frustration at the situation. And because of that block, they can't say it. So what you see is just anger. Um, or you may see them cry or, something like that. And I say, I don't mean that to sound mean. But you'll see it, like the internal struggle. Um, it's kind of like you ever kind of start to fall asleep? You're not quite fully asleep. Your brain's still awake, but your body is already clocked out. You know, you're you're like, I need to move. This happened to me all the time in math in school because my teacher was really good at putting me to sleep. Um, I would start to nod off, and the teacher would ask a question, and I'd know the answer, and then the teacher would see me nodding off, so ask me directly. And in my head, I'm trying to scream the answer out, but I can't. My body's already started to fall asleep. I'm just nodding off, but I could still hear what was going on. I knew what was going on. Just couldn't pull myself out of that brink, that like halfway point. Um, Patients with dementia can be in that state. They can be where their ability to respond to you and to interact with you is already gone, but the brain itself, their mind is still there enough to realize what's going on. Um, so if a point, the long-term point of this is if you have to do something, some kind of intervention for a patient that is experiencing signs of dementia, make sure you still tell them what you're doing and be detailed. Be like, I'm getting this for this reason. If it's gonna hurt, you can let them know you're gonna feel a pinch. Tell them because they may still be able to understand you. They can't process it right, or they can't get the information out to you or whatever. But they may still be able to hear what you're saying. Um, and so just be aware of that. Delirium. This is kind of the other end of the spectrum a little bit. This is a sudden change in mental status, consciousness, or cognitive processes. So where dementia is a slow onset over months or even years, delirium comes on fast. This is marked by the inability to focus, think logically, and maintain attention. Sometimes these can be tied into strokes, um, or drug use, that kind of thing. Delirium affects 15 to 50% of hospitalized people age 70 or older. Acute anxiety may be present in addition to the other symptoms, and usually their memory remains intact. So when they come out of it, they're going to remember what happened leading up to it. They may remember what happened during it. Just be conscious of that. Make sure the same thing. Just because they're not in their right mind doesn't mean you want to lose that patient affect. You don't want to start losing, or not maintaining their dignity, that sort of thing. Other important things to look for in the history are intoxication or withdrawal from alcohol, withdrawal from sedatives. Medical conditions such as urinary tract infections can cause this. Bowel obstructions, dehydration can cause this. Fever, diabetes, hyper or hypoglycemia. Here I am rambling off without the slides again. Anything that can cause an altered mental status can lead to delirium. Psychiatric disorders such as depression can cause this. Malnutrition, environmental emergencies like carbon monoxide poisoning, especially elderly that live at home alone in the winter times. They'll turn their heaters on and then they won't go back to them. The heaters just keep running and running. And if they close their windows, sometimes those old heaters especially will start to put carbon monoxide into the house. Assess and manage your patient for hypoxia, hypovolemia, hypoglycemia, and hypothermia. Those hypos are the big things that can cause an altered mental status. So, as advanced providers, when we're doing ACLS classes, Donna, you probably remember these, we talk about the H's and T's. There's 4 of your H's right there. So these are things that can cause altered mental status. These are also things that can cause cardiac arrest. So be aware when you're checking for patients with these, if they've got this and it's extreme, if it doesn't get fixed, altered mental status and delirium may be the least of your concerns. You may see changes in circulation, breath sounds, motor function, and pupillary response with these. So some critical BLS and ALS interventions may include supplemental oxygen. Surprisingly, that's such an easy thing to give. People forget to do it. Treat for shock, give glucose if you need to, if they're able to swallow, maintain their airway, and rewarm them if you can. During the physical exam, you may see changes. Well, I already said that. All right, syncope. I already mentioned that this is fainting, and this can be from anything. This can be from, well, I say it can be from anything. It can be from a couple of things. If they have this, just assume that it's a life threat. It may not be, but we don't know that in the field. A lot of times it's going to take blood work and tests in the hospital to figure out what the real cause was. So always assume that it's life threatening. until proven otherwise, just so you don't miss a critical treatment if they need it. Syncope is often caused by an interruption of blood flow to the brain. Um, it can also be caused by things such as severe hypoglycemia, where the blood's there, but the stuff that's supposed to be in the blood may not be there. An older person who has a period of unconsciousness should be examined to determine the cause of the syncope. That's not really that easy to do. You're going to kind of treat this like a stroke when you're assessing these things. So do a good neuro check. Look at their eyes, check their pulse, check their blood pressure, get your vitals, but check your pulse, motor, and sensory in their extremities. So muscle weakness, cramps, spasms, loss of balance or coordination are some things you're going to look for. If it's they look for or ask about tingling, numbness, itching, and pain. A lot of times syncopal episodes happen fast. They're going to be awake by the time you get there, so you can ask these questions. If they're still unconscious, that's not syncope. That's unconscious. That's a different thing. Syncopal episodes are quick. They'll pass out, hit the ground. A good example of this is a lot of times your elderly patients that are constipated and they're sitting on the toilet and they push too hard or whatever, and they actually, when they bear down to push, they actually hit their vagal nerve and get a response that knocks them out. And as soon as they fall off the toilet and relax, they wake up. That's an example of a syncopal episode. Or if somebody develops a heart block and the heart's not beating like it should, which causes an interruption in blood flow, very quick TIAs can do this. They can cause syncopal episodes. All right, for neuropathy, this is a disorder of the nerves of the peripheral nervous system in which function and structure of the peripheral, motor, sensory, and autonomic neurons are impaired. You can see this in diabetic patients that aren't even that old. If their diabetes is unchecked, it can lead to neuropathy in their extremities. It's usually why they wind up getting the amputations. Symptoms depend on whether the nerves affected are motor, sensory, or autonomic, and where the nerves are located. If it's autonomic, the big thing I want you to know, and I'm gonna jump straight to this portion, so we'll skip these. If they have a neuropathy in the musculoskeletal system, it's usually going to wind up being something like their hands or feet. It's not really that big of a concern for us. It's a concern for them in the hospital. But autonomic neuropathy is going to be things that are going to throw off their vitals. So changes in blood pressure and heart rate, constipation, bladder and sexual dysfunction. The nerves that control those aren't things that we normally can control. Like smooth muscle, we don't really control the smooth muscle of the bladder. We control the muscle that seals it off. So if they have a neuropathy in those areas, that's where you're going to start to see those dysfunctions. And moving on. Changes in the GI tract. Mostly it's going to be a reduction in saliva, which is going to start to alter how much of their food gets digested. They could lose their teeth. A lot of times they're going to have dental loss. And if their teeth are still there, but they're not anchored in like they should be, just due to degradation over the years, if something happens and they get hit in the face, they're more likely to lose those teeth and they can choke on it. Gastric secretions are reduced. Change in gastric motility can occur, so they're much more likely to get constipated. And like I said, they're not going to digest their food as well. A lot more of their food's going to pass through. It's not going to look the same on the way out as it did on the way in, but it's going to be undigested. They're not going to pull the nutrients from it like they should. And so if they're not eating well, let's say like calcium, we talked about that a little while ago. Let's say they are eating calcium rich foods, but they're not eating a lot of it. They may only get like 70% of the calcium that they would have gotten if they were younger and healthier. So just because they're eating it doesn't mean they're eating enough of it when you take into account the fact that they may not be digesting it all the way. Blood flow to the liver declines, which means that certain things aren't going to get filtered out very fast. If they're an elderly drinking alcohol, their body's not going to get rid of the alcohol as fast as they would if they were, say, 25, 30, somewhere around in there. Function of the small and large bowel changes little as a consequence of aging. However, like I said, they're more likely to get constipation, and sometimes that's medically induced. It could be some medicine that they're taking that's causing them to get constipation. It could be that they're dehydrated. A lot of times they don't drink enough water, that is. That can lead to constipation. Some age-related changes. We already talked about dental problems, decrease in saliva, poor muscle tone of the smooth muscle, which can lead to choking. If it's in the esophagus, it can lead to constipation. If it's in the intestines, they're more susceptible to heartburn, decrease in hydrochloric acid in the stomach. If you notice, all the fluids that aid in digestion are getting less. So your body is not really able to break it down as easy. Weakening of the rectal sphincter. Changes in liver predispose older patients to a number of problems, especially if they drink. Much more likely to get cirrhosis. They're much more likely to get liver spots. They could develop hepatitis more easily. Blood, let's see, we already said that. GI bleeding. Let me get to the right slide here. There we go. GI bleeding issues that affect older people can be caused by inflammation, which would be usually like an infection of sorts, or it could be maybe like the development of a ulcer, that sort of thing. Obstruction of the upper or lower GI tract, usually heralded by hematemesis. Jesus, I can't talk tonight. I need to get myself checked. Which means that they're throwing up blood. That's usually a problem. Bleeding that it travels through the lower digestive tract usually manifests as melena, which is black tarry stools. And again, when you're looking at that, if that's a part of your assessment, if it looks like coffee grounds, that means that the blood was partially digested. It's coming from further up in the tract. If it's bright red, then it's rectal bleeding that could be caused by something like hemorrhoids. If a patient has GI bleeding, they may experience weakness, dizziness, or syncope where they faint. And bleeding in the GI system can be life-threatening if it's big enough. It's just like any other bleeding. If it's not too much of a quantity of blood loss, then you're okay. It just depends on how much they're losing. Problem is that your small intestine alone is like 900 yards. You can hold a lot of blood in there. Some specific GI problems: diverticulitis, bleeding in the upper and lower GI system, peptic ulcer disease. You can have a problem with that. Gallbladder disease, bowel obstruction. And when you're assessing your patient, ask about NSAID or alcohol use. Both of those can cause GI problems in the stomach. Too much NSAID or aspirin, for example, can create ulcers. Too much alcohol can create ulcers that will also cause cirrhosis of the liver, which will even further impede their ability to break down food, absorb nutrients, get rid of toxins, that sort of thing. So they're going to have a whole bunch of other problems too. Presentation can include pale or yellow thin skin when the liver starts to fail. What's that called? You can see it in their eyes.
Jaundice.
Jaundice, yep. Frail musculoskeletal system, if they start to have a calcium deficit, like a bad enough one. Peripheral, sacral, and periorbital edema. Hypertension, fever, tachycardia, and dyspnea. You can run into any of those. Orthostatic vital signs. We kind of talked about that a little while ago. We know what vital signs are. Orthostatics just means that we're checking them in different positions, and that can be lying down, sitting down, or standing up. They should have the ability to restabilize their vital signs within 30 seconds of changing positions. Now, granted, the more drastic the position change, the longer it takes. So if they're going from lying down to standing up, it's going to be more of a change. It's going to be more of a time involved and that kind of thing. If they're going from sitting down to standing up, that's a little bit different. Or lying to sitting, that's an easier thing. They should recover faster from that. The only thing about orthos, I would say, defer to your paramedic. Is an easy way. That's an easy cheat way out, because you don't always want to do it. If they're showing signs of shock or low blood pressure, an altered level of consciousness, or spinal injury, don't don't do orthos unless you absolutely need it. If your paramedic told you to get them and you're seeing those signs, it might be worth questioning your paramedic. Tactfully, of course. Don't do it in front of the family, but just be like, okay, I can get the orthos. I just want to make sure you want them because I'm seeing signs of shock, or the blood pressure was already low and he's laying down. Can you help me catch him if he falls? Something of that sort to kind of trigger that thought. Hey, you know what? Maybe we shouldn't stand this guy up just yet. Acute abdomen. When we think back when we talked about that chapter, these are problems with your abdomen that don't pertain to the intestines. So this can be abdominal triple A's, abdominal aortic aneurysms, could be anything along the lines of um, appendicitis, can be acute abdomen. As far as aging patients go, those are going to be the big things. A lot of times, a lot of people wind up with appendicitis, and if they haven't had it yet, they may get it later in life. But triple A's is one of the most rapidly fatal conditions. Again, if they rupture an aortic aneurysm, you pretty much only have time to say goodbye. Um, if you rupture the aorta from the abdomen up, it's such a massive vessel that it takes about 6 seconds for them to bleed out. If at all possible, airlift these patients to the hospital just because you don't want to put them on too many bumps in the road. But if that's all you can do, that's all if it's Hurricane Sandy or Omega, whatever the last one was that came through and you can't get a helicopter up, you may have to drive them. The patient with a AAA most commonly reports abdominal pain radiating through to the back. Sometimes they'll have the flank pain, which will make you think um, kidneys. But the big thing about it at AAA is that the pain is going to be a tearing sensation. It's a specific type of pain. Don't lead them down that road when you're asking your OPQRST, but let them try to describe it. You can give them some examples. But if they say it feels like they're being ripped apart, torn in half, that sort of thing, that's usually an aneurysm that's causing that. And an easy way for you to tell also when you check your vital signs, get your blood pressure on both sides of the body. If they have an aneurysm, sometimes you're going to have your pulse is going to feel a little different, and your blood pressure is going to give you different numbers one side over the other. Changes in the renal system, it pretty much shuts down as you get older. Your kidneys, a lot of kidneys in elderly people have reached a point where they can't really filter everything like they should. Um, and then you wind up on dialysis. So as long as your patient is making their dialysis appointments on time, fantastic. That means that they are getting rid of the extra potassium that they don't need, that we would normally pee it out, but we can't if our kidneys aren't working. It helps us keep our blood pressure in check because, again, part of the reason that we urinate is to keep that balance of how much fluid we have in our body. Excess gets peed out. If you don't have enough, if you're dehydrating, then you don't pee. But when the kidneys start to fail, we rely on dialysis. Let's see, the BP would be low if low kidney function. Not necessarily. The kidneys don't really affect your blood pressure as long as your cardiovascular system can account for it. If the blood vessels don't dilate enough, then your BP would climb. Usually, if you can't pee, if your kidneys shut down, your fluid's going to wind up being in what's called the interstitial space. It'll leave your vessels because you don't need your heart's like, well, we don't need this fluid, so we'll get it out to maintain the proper blood pressure, and that extra fluid is just going to kind of chill out in your interstitial space. So you're going to see swelling. You're going to get swelling in your hands, swelling in your feet mainly because gravity is going to pull that fluid down. Um, so that's a sign that your kidneys are failing, is that you have that edema in your feet. It's going to kind of look like congestive heart failure in that sense, but all the other problems of CHF won't be there. They won't have the chest pain. They shouldn't have the problems breathing. It's just the kidneys aren't working, so they're holding extra fluid, but everything else is working fine. For now. The problem with that is if you can't get rid of those electrolytes, they build up, and then that causes other issues. So patients with bad kidneys will wind up on dialysis. When you're dealing with the elderly, you're going to get calls to dialysis centers to take care of people. You may get calls, especially this time of year, for patients who haven't been going to dialysis like they should. So, it's cold outside. They don't want to get out because elderly patients don't handle. Oops, didn't mean to change that. Elderly patients don't handle the cold as well. They prefer it warmer. And when it's cold or they get sick, they decide, you know what, I'm not going to go to dialysis. I'm going to miss this appointment. I'm just not feeling good. And then now they didn't get rid of the toxins that they needed to. So you start to run into those problems where you may be looking at, you get to a patient who is a dialysis patient, but they missed their last 2 or 3 appointments and they've got what looks like sepsis. And it could literally be, it could be hyperkalemia, which is too much potassium. It could be borderline sepsis, any of that stuff, because they haven't been going, essentially, they haven't been going to the bathroom, is what it's going to wind up being, because the dialysis is doing the job of the kidneys. And if they're not going, then it may as well be that they just didn't go to the bathroom, is a way to look at it. So all that bad stuff is still just circulating around in their body. Let me get to where I need to be. Incontinence is not a normal part of aging. Again, even if you have problems with your bladder, the muscle that we control to seal it off, you shouldn't really lose control of that. Skin breakdown, urinary infections can happen. If you do have these issues, as people age, the capacity of the bladder will decrease, so you have to go to the bathroom more often. 2 major types of incontinence are distinguished. So we have stress and urge. Stress incontinence occurs during activities like coughing. So if you sneeze, you might urinate a little bit on yourself. That's stress incontinence. Um, Urge incontinence is triggered by hot or cold fluids like running water. Even thinking about going to the bathroom, we used to play tricks on each other as kids. Put their hand in warm water, it makes them pee themselves, that kind of thing. I mean, I've never done that to anybody when they stopped over. That's never happened. What am I saying? The opposite of incontinence is urinary retention or difficulty urinating. In men, the enlargement of the prostate can place pressure on the urethra, making it harder to go to the bathroom. You'll feel that urge to go, but when you try to relax, it just nothing comes out and it'll hurt. Um, it's a miserable experience. Some supplements will do that too. Bladder and urinary tract infections can also cause inflammation, and in some severe cases of urinary retention, patients may experience renal failure. If you just don't go to the bathroom, if you can't get rid of it, it'll actually back up to the point where the kidneys can't push anything out anymore, and it can cause renal failure. Changes in your endocrine system. The endocrine system functions as a control center of the body, as we know. You're talking about your pituitary gland, your adrenal glands, all that stuff. A significant change that occurs in an older person is decreased metabolism of thyroxine, which is what affects your metabolism, your temperature, growth, heart rate, all that stuff. If a reduction in thyroid hormones can cause a condition called hypothyroidism, everybody loves to blame their thyroid for things like weight loss and stuff like that. Now, it could do it, right? I mean, hypothyroidism is a thing, and it's not just elderly that get this. People can get it. It's just not nearly as common as people think it is. Um, a lot of times, if that's what you've got, you could see lower metabolism, cold intolerance, weight gain, slow heart rate, that sort of thing. Other endocrine changes include an increase in the secretion of antidiuretic hormone, which can cause you to not get rid of fluids. This can causing a fluid imbalance. You'll start to see that swelling in the hands and feet and that sort of thing. Hyperglycemia can happen if you don't get enough insulin to get that out of your blood and keep it regulated. And increases in the levels of norepinephrine, possibly having a harmful effect on the cardiovascular system. We use norepi as paramedics, and we give a certain amount of it. But if you And that's a naturally occurring hormone in the body. If the body starts producing too much of it, it can have a negative effect, even though it is no, it is a good thing. It's just too much of anything can be bad. All right, give me a second here. Changes in the immune system. Infections are commonly seen in older people because they generally have an increased risk of infection and are less able to fight it off. So again, like I said, some people will get pneumonia and they'll just keep it. They can't really get rid of it. Anorexia, fatigue, weight loss, falls, any changes in mental status may be the primary symptoms of infections in these patients, particularly UTIs, especially in elderly patients. With that little bit of incontinence that you get when you get older, especially for females, you run the risk of, you have a higher risk of UTI. Um, some some people, as they get older, they start to get that childlike mindset of, I don't want to take a shower. Um, and it could be just because they just don't feel good. If you're running a fever or you're just too tired, you're like, oh, screw it. I'm not going anywhere. Nobody's coming to see me. So I'm not going to bother with a shower. But then with that, or I don't want to change my clothes. I used to see that a lot in nursing homes. But when you don't change your clothes, you don't get a shower, you run the risk of getting UTIs, especially, like I said, in females, because your pipes aren't as long. Pneumonia and urinary tract infections are common. When an infection occurs, signs and symptoms may be decreased or minimized by the patient because of loss of sensation, lack of awareness, fear of being hospitalized, and some um, medications can kind of mask things. Changes in your musculoskeletal system. Aging brings a widespread decrease in bone mass in men and women, but especially among postmenopausal women. Women are much more likely to break a bone postmenopausal than a guy is. So when it comes to patients falling, be aware of that. It's bad enough. I mean, guys are high enough risk of it to give you that pucker factor already, but women are even more so. Joints lose their flexibility and may be further immobilized by arthritic changes. And a decrease in the amount of muscle mass often results in less strength. Changes in physical abilities can affect older adults' confidence in their mobility. They're not going to want to move around as much. And with that comes those problems we talked about earlier for sedentary lifestyles. Muscle fibers become smaller and fewer. Motor neurons decrease in number, strength declines. Ligaments and cartilage of their joints will lose elasticity, and the less they want to move, the less they move, the less they'll be able to move. Cartilage goes through a degenerative change, and then they can start to develop issues like osteoporosis. But the stooped posture of older people comes from the atrophy of the supporting structures of the body. So as their spine starts to atrophy and their muscles start to kind of wear out, they'll start to stoop down. They may not get the true like curvature of the spine or whatever, but just the posture in general is going to decrease. Um, they may start to hunch a little bit, not to an extreme, but you'll just see it in older people. They don't move as much. They kind of waddle around rather than walk. We do get smaller in height as we get older, just because gravity is compressing on our spinal cord or spinal column, rather. Sorry. Depending on what your career is, those of you firefighters in here that have to wear 70 pounds worth of gear and occasionally pick humans up, you're going to lose height faster than people who work less strenuous jobs. Osteoporosis, a condition that affects both men and women, is characterized by a decrease in bone mass, leading to reduction in bone strength and greater susceptibility to fracture. So that is a common thing. That's basically just the name for bones getting more brittle as we get older. This can be caused by genetics, smoking, level of activity. The more you work out, or at least go for walks, that kind of thing, the better your bones are going to be. Diet will cause issues, alcohol consumption, hormonal factors, and body weight. The most rapid loss of bone occurs in women after menopause. So I already said that. Calcium and vitamin D supplementation is another treatment for the condition. Um, as long as your patients are keeping up with things, they're taking the right amount and not overdoing it. The body can actually only handle so much vitamin D. So too much of it is a problem. Same thing with calcium. Too much calcium can throw your EKG off. So they can start to mimic heart issues when really it's just too much calcium. Osteoarthritis is a progressive disease of the joints that destroys the cartilage. So it's not the bones, it's the cartilage. And it can actually promote the formation of bone spurs in joints. Anybody ever watch wrestling back in the like late 90s, early 2000s? Stone Cold Steve Austin had bone spurs in his neck, I believe. And even Dwayne Johnson, when he was wrestling, the reason he didn't go pro NFL was because he had some kind of bone issue. I think it was bone spurs as well. That's how he wound up in wrestling rather than football. Results from wear and tear, and in some cases from repetitive trauma to the joints. This affects 35 to 45% of the population that's over 65, and it can affect several joints of the body. So there you go. Patients complain of pain and stiffness. It gets worse with exertion, and patients are typically treated with anti-inflammatory medications, physical therapy. So they'll be on what is it? Naproxen, Aleve. That's it. They'll take like 2 Aleve a day or whatever. In fact, a lot of your Aleve bottles are designed to be opened by people with arthritis. They're really huge rubber caps that you don't even have to grip it. You can just put your palm on it and twist, and it'll open the bottle. That way you can get it out easy. The skin will change as people get older. It becomes less pliable. You get liver spots, that sort of thing, and you can see obviously it's their skin. So if you think about what an elderly person's skin looks like versus your own or versus like a teenager's, it's apparent that this stuff changes. Bruising becomes more common. The sweat glands don't respond readily to heat because of atrophy and changes to the tissue of the dermal layer of the skin. Your patients will have a harder time staying warm. So you're going to find that a lot of times, and a good rule of thumb is if you're comfortable, your patient is freezing when it comes to geriatric patients. This is a big issue too, because what if they are in a house by themselves and they can't pay the heat, especially down there surprisingly in the south, it's a bigger issue than it is in the north, even though we have like 6-degree winters and stuff. Up here, the utilities can't cut you off. They're not allowed by law. You don't have to pay your bill in the winter months. They cannot turn your gas off. They can't turn your power off because then it would become a life threat. But down in the south, though, you guys getting those kind of temperatures is so rare that you don't pay your power bill in December, you're getting shut off. If an elderly person can't pay their bills, the power company doesn't know that it's a 65-year-old person living alone. They'll shut them off just like anybody else. And if it gets down into the 50s, which is not that cold, especially, and that's easily doable down there, that's enough to throw people into hypothermia, especially the elderly who can't really maintain a warm core temperature as well as we can. So you actually run the risk of seeing that pretty easily down there. For ulcers, you may see them in various stages of development. So stage 1 is non-blanching redness with damage under the skin. Stage 2, ulcers, blistering or ulcer that can affect the dermis or the epidermis. Stage 3 is invasion of the fat layer, getting lower and lower. It's just like a burn. And then stage 4 is invasion into the muscle or the bone. So just know that usually you're going to see these on patients that don't move very much. If they're bedridden or they don't want to move, they stay on their chair. Again, it's funny because we would always joke with a coworker of mine at the fire department down there. He had a family. He had newborn babies. He never really got to sleep at night. So when he'd come into work, he'd just go to bed. We'd never see him all day long. We wouldn't see him. And it got to the point where our assistant chief of EMS would get on the intercom every hour and a half or whatever, and tell him to roll over so he didn't get bed sores. Decubitus ulcers can be painful and cause complications such as bleeding, sepsis, and bone inflammation. So just keep that in mind. Toxicology. Surprisingly, elderly people are at pretty high risk of doing things that people in their teens and 20s wish they could do, like drugs. alcoholism, those kind of things. When you get to be older, a lot of times you're not doing anything that requires a drug test. Depression is pretty high in elderly, so because if you know, think about what they're going through, right? Their bodies aren't able to do what they used to do. Their minds may be having problems. People that they knew and grew up with may be dying off. Their families have all grown and gone on to do their own things, and they may not be seeing their family like they used to, and they deal with the isolation of it, the medical issues. It's really common, or else I'll say it's really not uncommon for elderly to become alcoholics, to get into certain drugs, to try to get, particularly psychedelic drugs or drugs that put them in an out of their head state. Um, just because it makes it easier to deal with the BS that they're dealing with at that point, and the depression that sets in and all that stuff. Um, so that's a big issue there. And I probably got ahead of myself, but toxicology can be caused by a couple of things. We talked about, I'm drawing a blank, renal failure earlier in patients on dialysis. If they miss dialysis appointments, that can cause issues with their toxicology, just decreased function, especially if they're not yet on dialysis. They don't realize they need it. They hadn't gone to the doctor. That span where their kidneys are failing them can cause issues. Um, Decrease in the liver, we already mentioned, that can cause issues because the body can't process things and get the toxins out. Decreased liver function makes it harder for the liver to detoxify the blood and eliminate medications and alcohol. If they take a medication in the morning for pain and they forget that they took it and they start to hurt again, they're going to take more of it. With the decreased liver function, they're more likely to have an overdose on prescribed medications. Typical over-the-counter medications used by older people include aspirin, antacids, cough syrups, and decongestants. And even myself, I have overdosed. Well, not really an overdose, but I've overdone it with antacids before. I have a condition that gives me heartburn from the ninth circle of hell if I don't keep up with my medications right, and I usually use Tums to kind of take the edge off if it overpowers my med. Um, and before I got put on this med by the gastroenterologist, it was just Tums. That's all I took, and I would take a half a bottle to stop myself from throwing up blood or having to sleep in a chair or something like that. And too much of that stuff is great for Tums stock, but it sucks for EKGs when you're doing your firefighter physical because it inverts the P wave, or I'm sorry, not the P wave, the T wave. And then people look at you like you got a heart condition at 32 years old. But a lot of people think that just because the medication is sold over the counter, that it may not be dangerous. And that's not the case. Some medications like Robitussin or at least they used to, have an ingredient in them that if you took too much of it, it would put you out of your head. In fact, when I was in college, that was a trend. People were drinking bottles of Robitussin and going on what they called robo trips. So they would drink the bottle, try not to throw it up. It would affect them, and it would be like playing a video game of yourself. You're seeing yourself in third person. You can't really feel things properly. It was really messing with your neurologic function. Um, That's just one example. Sudafed's another example. And granted, yeah, people use Sudafed to make meth, but you can take a whole bunch of that stuff, just the med, to get high, and it's dangerous. You can die from it. So not not just prescription medicine is dangerous. You can have problems with acetaminophen. Too much Tylenol will affect your liver. Too much aspirin will tear up your stomach. That kind of thing. Polypharmacy refers to the use of multiple prescription medications by one patient. Who's pretty much everybody that fits this age group is going to typically have a lot of medications that they take. Um, People I worked with who weren't much older than me are already on hypertensive medications or medications for high cholesterol, medications for heart issues and stuff, and they start piling that on, and then you get doctors who give you one medication and then they'll give you another medication for a side effect and then another medication for that side effect, and before long you've got a shoebox full of stuff that you only had one issue. but all those other medications are to fight those side effects that you have to deal with. Both overdose and underdose can lead to serious problems. If they were given a medication for a reason and they're not taking it, then the problem's still there. Not only that, some medications, if you don't take enough of it, the medication itself will harm you. An example would be atropine, I believe. Um, if you don't, atropine is used to raise your pulse rate a little bit. If you don't take enough of it, if you get a dose of atropine but it's too little, it'll actually cause you to go bradycardic rather than tachycardic. That's one example. Um, dopamine. Dopamine we give in a range of anywhere from 2 to 20 micrograms per kilogram of a patient's weight. If it's too low of a dose, it just makes you go to the bathroom. That's it. That's all it does. Doesn't do anything else for you. If you get too high of a dose, it really affects your blood pressure. Like it'll skyrocket it. So they have to find that right range. And if you don't take enough of it, you fall into too low of a range, and it gives you all kinds of different issues. Medication noncompliance in older patients is also an issue and may occur because of financial challenges if they just can't afford their meds. Inability to open the containers sometimes is an issue. They call it child proof, but a lot of times it's more adult proof than anything. And impaired cognitive vision and hearing ability. Also, they may just flat out forget that they took it. All right, behavioral issues. Depression, like I said, depression is huge among the geriatric patients because think about where they're at in their life. They're not able to do the things that they used to do, so they start to worry about losing their independence, or some of them have lost their independence. They wind up in nursing homes, and I've seen one of the reasons why I can't be a CNA in a nursing home anymore is I've seen too many patients dropped off and just abandoned by their family. They were put there because their family just didn't want to deal with them, and by that I mean they never showed up, they never visited. Um, I've had elderly patients that I've taken care of that had like pictures of their of kids in their room or whatever, and when you ask about them, they're like, "Yeah, that was them 10 years ago. I haven't seen them." This fourth grade picture is somebody that's in college now or something, and they just haven't. They don't see them. Family just leaves them alone. Um, the good thing is depression is treatable with medication and therapy, but they got to get that. If they live at home, a lot of times the depression goes undiagnosed, and then you run into issues with suicide, substance abuse, isolation, prescription medication overdoses, any of that stuff can be a problem. So, speaking on suicides, most older adult suicide victims have recently been diagnosed with depression, go figure, and have seen their primary care physician within the month before the event. That's the scary thing. They're getting help, they get diagnosed with depression, and I don't know if it's just nothing's being done about it, or um, if we're still just not recognizing it as being a real threat or whatever. Yeah, no, I can't do it either. I tried, but I get too attached. EMS is more my speed because I'll find you, fix you, and send you on your way, as opposed to pretty much just adopting you as my grandfather and then watching you pass away again. Most older adult suicide victims have recently been diagnosed. I already said, I'm sorry. Older men have the highest suicide rate of any age group in the United States. At the highest risk, white men age 85 and older who use firearms as their suicide method of choice. Older persons who attempt suicide choose more lethal means than younger victims. And I think that's because they really want to get it done. Um, your younger people have a little bit more of a will to live. Sometimes their suicide attempts are more of a cry for help, and they're hoping that it's something that they can come back from if it fails, or they're afraid of the finality of it. They're afraid of the pain. I don't know, but usually if it's an elderly person, they're not concerned about that. They want to get it done. And the sad thing about that too is that that cry for help is not there. Um, a lot of times they just do it. You don't see the signs. It just happens. Common predisposing events and conditions: death of a loved one, physical illness, depression and hopelessness, alcohol abuse, alcohol dependence, loss of meaningful life roles. Again, like Empty nest syndrome. My kids still live at home, but I know that that's going to be a major issue when my kids grow, is because my entire adult life I've been a dad. So when they're not here anymore, that's going to be hard to deal with. When assessing the patient who is displaying signs of depression, it's appropriate to ask if he or she is considering suicide. You can ask them, and you should. Have you had thoughts of suicide or thoughts of hurting others? Usually, you're more worried about them hurting themselves. And if they say yes, ask them if they have a plan. Something to keep in mind, and I was having this conversation with somebody recently about suicide. It's pretty common, and it's not really a red flag. If you have the thoughts of, you know, boy, this would be so much easier if I just wasn't here. If the world would be better without me. When when the world around you goes to shit, sometimes that's going to be the thought process you have, and everybody has those. That's actually pretty normal. When it becomes a problem is when you start to figure out ways to not be here. So it's one thing to say this would be easier if I wasn't here, or this problem would be fixed if I wasn't here. It's a real red flag, and this suicidal ideation is not that. Suicidal ideation is, I don't want to be here anymore. Here's how I'm going to do it, and you start making a plan. Um, that's the freak out point when you really need to get help. If you don't take yourself, if it's somebody else, let's say you know somebody else is thinking of that sort of thing, that's when you need to escort them. Don't leave them alone. Take them to get help. All right, so the GEMS diamond. This is interesting because I just got my GEMS instructor today. Um, the NAEMT, National Association of EMTs, has a bunch of different classes that focus on different things. And the geriatric EMS class, or the GEMS class, they actually teach a different assessment method, kind of similar to the pediatric assessment triangle, but this is a 4-step process. Um, the GEMS diamond was created to help you remember what is different about older patients. So this isn't really going to change your assessment as an EMT, but it's going to help you keep certain things in mind. All right, so G stands for geriatric patient. First of all, remember that your patient is an elderly patient. All right, so the first step is just understanding, and you can think about this on your way to the call. Your patient's going to have some differences than a 30-year-old would have. Be familiar with the normal changes of aging and treat older patients with compassion and respect. E stands for environmental assessment. Assess the environment can help give clues to the patient's condition. If you walk in and it's freaking cold in that house to you, like I said, if it's cool or cold to you, it's Arctic to your geriatric patient. Um, Preventive care is very important for a geriatric patient who may not carefully study the environment, may not really realize where risks exist. Another thing to keep in mind too, when you walk into somebody's house, it's a geriatric. Real quick recap, pop quiz. What's the leading cause of death um, as far as trauma is concerned with elderly patients?
All.
Falls. So if you walk into their house and you see a bunch of loose rugs, like throws and stuff like that on the floor, things that could be tripping hazards. And I know that's not dealing with your patient, but when you're walking in and you're doing your size up or whatever, and you see a whole bunch of stuff on the floor that they could trip over, move it out of the way. The goal is to help them maintain their independence. We're not there to take them out of their homes and put them into a nursing home. Um, so if you walk in and you see environmental things, tripping hazards, stuff like that, that might make you have to go back out there, or cause a lot of problems, you can fix that stuff on the spot. Fix the throws so that they're not all crumpled up, or just remove them, get them out of the way. Um, if there's a section of the house that's um, particularly cold, figure out why. Maybe the vents are closed and the elderly person can't reach the vents to fix that. Just you can check that stuff out while you're walking toward your patient, or after the patient is taken care of and you're walking out, that kind of thing. Just give a quick look around, see if you can help make it to where their home is more habitable so that they're better off. Anyway, M stands for medical assessment. Correct slide. Older patients tend to have a variety of medical problems and may be taking numerous prescription, over-the-counter, and herbal medications. The big herbal stuff is pretty big right now. I know it seemed bigger when I was in college in early 20s. I don't know if I've just lost contact with the people that are doing that stuff, but I know that it's still pretty big today. Make sure you get a good medical history. And then S stands for social assessment. Older people may have less of a social network because of the death of a family member, friends start to die off, that kind of thing. And you know, we lose touch with future generations as we go through our lifespan and development. Um, when we just reach a different stage of life, we fail to connect with people who are in a different stage. So younger people, we don't connect with them that well. We start to alienate them and say, "Oh, kids today and this problem and that problem." We forget that we were there too, that we went through the exact same thing. We just don't think the same way anymore. Um, but they're going to be a little bit more isolated. They may also need assistance with activities of daily living, or ADLs, if you've ever seen that acronym. So cooking, going to the grocery store, that kind of thing. Consider obtaining information pamphlets about some of the agencies for other people in your area. Um, that could be anything from like food kitchens, some nonprofits that will make proactive visits, if not your own ambulance company, to do blood pressure checks, make sure their medicine is present. They can do like medication counts to make sure that they still have the medication to get through until their next refill, or they may go get the refills. I know Walgreens does. They have like not all of them. I don't think all of them do it, but I know the one in Covington does. They do a like a delivery. They will bring the medicine to the elderly patient's house so that the elderly don't have to get out and go to the pharmacy. Um, I know there's another company that's getting pretty big that does a lot of proactive like welfare checks and stuff like that, and they'll go in and do exactly like I was saying in the environmental portion. So I mean, stuff like that is fantastic, and it's really good to have in your community. If you don't have something like that, consider starting it, or see if you can get your ambulance to kind of jump in on some of that stuff. Because if you can be proactive and stop, it's much faster to go in, spend 2 minutes, say hey to your elderly patient, get a blood pressure. You don't have to hook them to a monitor, but just go in and see how they're doing, and go through that GEMS assessment with them. Look around, see if you see anything that needs to be fixed. If you can stop them from falling and having to make you take an hour out of your day to go to the hospital, it's just much better for them, and it's much better for your system as a whole. Because while you're out carrying somebody with a broken leg that could have avoided a fall in the first place, somebody may have a heart attack, and you're not there for it. That kind of thing. All right, cool. All right, so I didn't like the sheriff's department's a good idea. Law enforcement doing it is good because it also gets police out in a good light. Nobody ever likes seeing the cops. Um, that gives them something proactive to do that's good for the community. All right, we're gonna take another quick break. A little bit less than 10 minutes. Be back 10 after. So a 7-minute break at 8:10. We'll continue up. I think we're gonna be able to finish up after this. All right. I know I'm a minute early, but we're going to go ahead and get through it. And we're going to skip some slides, the stuff that has to do with the assessments, because there's really not anything different in your assessments. Um, the stuff that you need to know is going to be most of the special considerations and things. So I already skipped a chunk of slides. Once we get through trauma, there's going to be another chunk of slides I'm going to skip because it's basically the assessment process all over again. And it's just a complete and utter waste of time. I even looked through it just to see if there was anything that would be important to glean from it that wasn't already mentioned in every single chapter up to this point. There's not. So I don't like hearing myself talk that much. I'm sure y'all are getting sick of it by this point too. So we're going to stick to the stuff that will actually benefit you in this chapter. So let's talk about trauma. In general, the risk of serious injury or death is more common in older patients who experience trauma than in the younger adults. Just keep in mind, their ability to recover is slowing down. They wind up having issues with bleeding, um, limited physiologic reserves. Normal effects of aging on the body can affect things, and existing medical issues that just kind of compound things. Not to mention the medical issues themselves, but also the medications that they're taking for those issues. Again, hypertensive medications and beta blockers can really screw up somebody's ability to compensate during shock. Physical findings in an older adult may be more subtle and more easily missed. The mechanisms that cause serious injury in older people are usually much more minimal than in younger people, so it doesn't take as much to hurt them. Recuperation from trauma is longer and often less successful in older people. And a good example of this is, again, they could be walking across the living room and fall from a standing position, fracture a hip, whereas we fall from a standing position and you're like, well, that sucks. So maybe I should stop drinking. And you get up and nothing's wrong with you. But for elderly patients, it's much more easy to do damage. Many injuries in older people are under triaged and undertreated because we underestimate how bad the mechanism affected them. We forget that it takes very little to cause a whole lot of damage. Because of changes in the body, older pedestrians are more likely to have life-threatening complications after being struck by a vehicle. Again, it goes into your mechanism. A mild mechanism of injury can be very significant to an older person. Older people are more likely to experience burns because of altered mental status, inattention, and compromised neurological status. We mentioned that earlier. As their nervous system kind of shuts down, or not shut down. I'm sorry, that's the wrong way of saying it. But as it ages and those neurons are lost, the synapses kind of start to dumb down a little bit. The response time is longer. So if they come in contact with the burning surface, even though it's only a fraction of a second, that longer response time makes it that much worse of a burn. Whereas somebody in either a child or an adult would more quickly pull away. There's a higher mortality from penetrating trauma in older adults, especially in the case of gunshot wounds. The chances of internal bleeding are just astronomically higher. A bullet bouncing off a bone in a healthy adult may not really do that much damage to the bone. But in an elderly person, it will most likely shatter whatever bone it hits. And then again, that causes more internal bleeding. Falls are the leading cause of death, and as well as non-fatal injuries, so fatal and non-fatal. But falls are the big bad wolves. Nearly half of fatal falls in geriatric patients result in traumatic brain injury. So the hits are a problem, the joints are a problem, and the head is a big issue. Anatomic changes in trauma. Changes in the pulmonary, cardiovascular, neurologic, and musculoskeletal systems make older patients more susceptible to trauma. Again, we talked about the brain shrinking in size. This leads to higher risk of cerebral bleeding because the brain has more room to move. And when it moves, those blood vessels have a bigger chance of shearing. And then you have hemorrhage in the brain, in the skull. Skeletal changes cause curvature of the upper spine that often requires additional padding during long board immobilization. It's one of the big reasons why we don't use long board anymore. It's people keep forgetting that. If you do have to use the board, use the board. All right. Don't not use it just because we don't want to give it to everybody. It's like oxygen. But if you have to put a person on the board, just understand that if you do it wrong, and it's so easy to do wrong because people take it for granted. They're like, I'm an EMT, I do this stuff all the time, and I'm just going to throw this person on the board and strap middle, bottom, top, and that's all I'm going to do, and your patient dies. Pad it, pad those spaces, give them something to support the curvature of their spine, something to support their neck, instead of just being on that long flat piece of plastic or wood, and then your patient asphyxiating on you. A geriatric patient's overall physical condition may lessen the ability of the patient to compensate for the effects of even simple injuries. So if a patient winds up having blood clotting issues and they just get a small cut on their arm, they may just bleed and bleed and bleed and bleed, and it becomes a big issue. Um, Osteoporosis usually leads to the higher risk for fractures, especially of the hip. So keep that in mind. Some contributing factors: stresses of ordinary activity, a standing fall, vitamin D and calcium deficiencies, metabolic bone diseases, and tumors. And injuries to the hip tend to be recurring. If they have fallen and hurt their hip and they recover from it, they're more likely to fall and hurt it again. Older patients with osteoporosis are also at risk for pelvic fractures. Recovering from these kind of injuries can be complicated for an older person. It's not just like a normal bone break. With age, the spine stiffens as a result of shrinking of disc spaces, which is going to make their vertebrae brittle. It's also going to make it harder for them to do trunk movements. Your spine is designed to bend you forward, back, left, right, and it allows for a little bit of twisting. As we get older, we start to lose that. And with that means that if they do fall, they're going to be less likely to brace themselves for impact, which is another reason why you get those injuries sometimes will be worse than normal, is because you would think that like a normal person like me and you, if we fall to our side, we can kind of twist and roll and curl in if we need to or whatever. An elderly patient may not be able to do that. So the mechanism is going to hit them differently. When you're picturing somebody falling, that may not be how it played out for them. Because brain tissue shrinks with age, older patients are more likely to sustain closed head injuries such as subdural hematomas. Serious head injuries are often missed in older patients because of the mechanism of injury. It may seem relatively minor. You're like, well, that was just a mild little hit, and it may not even, like blunt force, for example, may have been from something fairly soft. But the movement of it, not necessarily the material, but the movement of their head could have caused issues where we normally wouldn't have had that. Other factors that predispose an older patient to a serious head injury include long-term alcohol abuse, recurrent falls or repeated head injury, and anticoagulant medication. So environmental issues, temperature regulation slows with aging, which is owing to slowed endocrine system, slowed circulation, decreased sweat production in the skin, chronic disease, medication use, and alcohol abuse. Half of all deaths from hypothermia occur in older people because, again, they can't maintain their core temperature very well. Most indoor hypothermia deaths involve geriatric patients. Harsh winters can be an issue, but again, most people stay inside up here, and we're even people who can't pay their bills don't have to worry about their utilities being shut off during the winter months. So that's a little misleading. Yes, it does happen. Usually it happens because people may get stuck in their car if they get snowed in and they're on the roads, or they have a wreck, or they decide for whatever, let's say they don't have a home, and they sleep in a vehicle. That's happened, and people can freeze to death there. Hypothermia can also develop at temperatures above freezing when an older person is exposed for a prolonged period of time. It can be, think about it like if you're submerged in water, all right, and the water is 80 degrees. That's some nice Gulf temperatures, 80-degree temperatures. If you're stuck in that for a long time and your body is supposed to be 98.6 degrees, if that water temperature pulls you down just 5 degrees, it's enough to throw you into hypothermia. And if you're young, you really don't have that problem. But if you're an elderly patient, then you are at a higher risk of that. So it's not like you got to be in sub-zero temperatures to have these issues. So you guys down there in the south, y'all could see this too. All right. This portion right here, I'm going to kind of skip through because this is just your assessment all over again. And again, it's not, there's nothing to it that really pertains to geriatrics. So let's skip through this and get to assessment of falls. All right. Falls can be caused by a medical condition such as fainting or syncope. Remember, that's going to be your buzzword for that. A cardiac rhythm disturbance or medical interaction. Some medications are synergistic with each other where you have the strength of one and the strength of the other, and they don't add together, they multiply. So it's just that much harder on somebody. Whenever you assess a geriatric patient who has fallen, it's important to find out why the fall occurred. So get a good set of vitals. Ask them when the last time they ate was. If it's a diabetic issue, it could have been a hypoglycemic attack. Consider that the fall may have been caused by a medical condition. So get their medications, see what they're taking. Um, they could be on beta blockers that stops their heart rate from climbing, but for whatever reason, something happened that was supposed to raise their heart rate to compensate. It couldn't do it because of the medication, and then they dropped out for that reason. If they did fall, always consider the fact that the fall may be life-threatening. Again, any fall, really, a good rule of thumb is it's a life threat until proven otherwise. For nursing homes, with many of you geriatric patients with whom you interact, the call will occur at a nursing home or other skilled care facility. The skilled care facilities may have various levels of training. I'm not saying that the people there don't know what they're doing or anything. That is not what I'm saying. However, there's a couple of factors that play in. It could be that they don't have some training. Some nursing homes just don't. It could be that they're overworked, understaffed. Any of those other things can play into it. So just keep that in mind. You may show up because there's 50 people living in the home that need help, and then there are only like 6 people working that day or something. The kind of facility will depend on the type of care needed. Nursing homes are facilities that serve patients who need 24-hour care and are sometimes a step down from an acute care hospital. So they may be attached to a hospital and have those higher levels of care. They may not be. Um, Calls to these type of facilities can sometimes be challenging. Sometimes you're going to get called over there for things that are just completely stupid, for lack of a better word, and you're gonna walk in and be like, why did you need me for this? You have a nurse standing right there. um, Sometimes it's not that they couldn't take care of it. The nurse may be sitting there shaking her head too, going, yes, I could have fixed this. But just like we're protocol driven, so are the nursing homes. Their nurses may be forced not to intervene. Their protocols may just say call 911, and that's got to be infuriating to a nurse. I have to believe that if it's something as stupid as the patient is hypoxic and the oxygen is right there, but for whatever reason they can't do it because protocols dictate that they can give oxygen, but if it becomes an emergency, it's just call 911, even though the emergency could be fixed, but the protocols don't allow it. Sometimes you're going to run into that, and sometimes you're going to run into people. I mean, I've had some pretty bad um, nursing home runs where it wasn't that they couldn't do something; it was that whoever did it should have been face palmed. That happens too. The most important piece of information you need to establish immediately if you show up to these is what is different today that made the patient, made them call 911. Keep in mind, usually independent elderly don't live in a nursing home. Most of the time they're there because something's wrong, right? It's a long-term issue that they can't take care of themselves. So when you walk in, you're keep that in mind. There's going to be something wrong with them, something usually mental or it could be physical, but most of the time it's Alzheimer's or something of that sort. Um, What's different? They deal with Alzheimer's every day. That's not a reason to call 911. What's the reason they called? Infection control needs to be a high priority for EMTs when you visit these facilities. A lot of elderly may have immunocompromised systems. They may get sick easy. They may have a sickness that you don't want to bring back with you. So good hand washing, and an infection in an older person can lead to life-threatening sepsis. So if anything, definitely be very careful about possibly spreading things to the elderly. Just like in hospitals, you have the risk of staph infections, MRSA. These things, they usually do a really good job of keeping things under control. Infection control is huge in long-term facilities like that. But you are an uncontrolled, unplanned for visitor. So be aware of that. Make sure you wear your gloves. Make sure you wash your hands. It's not just about keeping you safe, like we harp on all through this class. It's also about keeping them safe, because you may be bringing something in with you from a call you had 10 minutes ago that could get to be a really critical thing for people. All right, dying patients. As older patients are living longer, more terminally ill patients are choosing to die at home rather than in the hospital. And oh God, I think it's the next class. No, it's this class. Um, some of your classmates essentially do home health and hospice care. Um, so y'all could probably speak to this better than I can, because I don't have any experience in that field. But a lot of people are preferring to just never go to a hospital. They just want to be taken care of, made comfortable, so that they can die peacefully in their homes. Often the patients already reached the acceptance stage that their death is coming. They get there a lot of times faster than the family does. So when you're dealing with patients in this sense, um, you you your biggest issues, your biggest gripes are going to come from the family, not the patient. Dying patients receive what is called palliative or comfort care. In other words, they know that they can't be fixed. The medical teams know they can't be fixed. They're just trying to make them feel better for what time they have left. It does not hasten or prolong death, um, but it focuses on just relieving the pain. Your interaction with a dying patient will have a long-term effect on the family. Be understanding, sensitive, and compassionate, and determine if the family wishes for the patient to go to the hospital or stay in the home. Again, they're expecting to die. The family is expecting them to die. You can't fix them. This is a weird situation for an EMT, because our goal is to fix you and send you on your way. That's just not something that we can do with those patients. Advanced directives. Think back to I think it was our second chapter where we talked about advanced directives. This is a specific legal paper or document that has the patient's wishes spelled out from back when they were still sound of mind to be able to tell you what to do or what they wanted. Um, this is pretty common for us now. So as long as it's in date and a valid form, we respect that. Doesn't matter if a family member disagrees with it. That is the patient telling you in advance what they wanted, and it trumps whatever Uncle Tom or anybody else has to say about it. An advanced directive may include the DNR. Um, Remember, DNRs have to be renewed, and you need that in your hand before you withhold resuscitation. So if somebody tells you there's DNR and they can't produce it, it doesn't exist. Start treating. If you're unsure, start treating. And if you want a CYA, then contact med control. But I would say even with contacting med control, start CPR if you're not sure, and let the doctor tell you to stop. That way, you're you're kind of stuck between a rock and a hard place, but you're putting yourself in the best defensive position, and you're putting your patient first, which is what we want to do. When transporting patients from nursing homes, consider the following general guidelines. Patients have the right to refuse treatment, including resuscitative efforts, provided that they are able to communicate their wishes. A tattoo of DNR does not count. In fact, it really sucks if somebody gets that, because if they change their mind, they have a tattoo of DNR over their chest. A DNR order is valid in a healthcare facility only if it's in written form, um, and by the order of a physician. That's going to be part of it. You should periodically review state and local protocols and legislation regarding advanced directives because they can change. There's a lot of lobbying groups out there that want to see those things go away, um, because they feel like you shouldn't. It's almost a form of assisted suicide to withhold resuscitative efforts in their argument. Um, when you're in doubt, like I said, when in doubt, resuscitate them. Just try. Let the doctors tell you no. All right. And just as in all the others, we're going to end with the absolute worst topic to possibly talk about: elderly abuse and neglect. Um, this is defined as any action of the part on the part of an older person's family member, caregiver, or other associated person that takes advantage of the older person's person, property, or emotional state. The abuse doesn't have to be physical. Hold on, what's going on? Does that go with all DNRs, like with the doctors having to have it too? Sorry. No, you can apologize. If they're in an extended care facility, the doctors have partial say over their health care. That's why they're there, right? So if you're dealing with a DNR, what do you? Okay, do me a favor, unmute, um, and let's talk for a second. What are we talking about?
So if a patient is in the hospital dying, but not to like it's a slow death, can family say, she has a DNR in case she goes into cardiac arrest?
Okay, yes, in a hospital, that's not an extended care facility. So if you're talking about like in an ER or an ICU, the DNR applies without the doctor's signature. What that slide was referring to is if you're in an extended stay, like a nursing home. Patients in nursing homes are there because they're not independent. So part of the admission into the nursing home, a lot of times, and correct me if I'm wrong, y'all that are CNAs that have a lot more experience in this than me, but they're signing over the family because otherwise the family has to be contacted for everything that happens to the patient if the patient's not in their right mind. So a lot of the medical decisions are signed over to the nursing home so that they can give those prescriptions that if the doctor writes a treatment plan up or prescribes a medication or something, they can make the patient, to an extent, they can make sure the patient takes the medications. Obviously, the patients are still adults. They can say no to things, but there is a little bit of authority that's given to the nursing home. So when it comes to something like a DNR, which is a life and death situation, if a patient's got a DNR, the a physician at the nursing home has to put their signature on it as well because they have a little bit of that power of authority to do so. Um, Again, I know that if they're in an extended care facility like that, they have to have it. I'm 99% sure that that's the reason why, but it's an educated inference based on what I've seen. That's Nobody's ever actually showed me that in writing. Okay. But yeah, no, when it comes to a hospital though, they're there to get fixed and go home. So the doctors in the hospital don't they don't have that authority. So a DNR in the hospital would be just a standard DNR. It'd be the same as if you were in their bedroom. All right, elder abuse and neglect. Abuse can result from acts of commission, so words or actions that cause harm, such as verbal, physical, or sexual assault, just like anybody else. The problem is that elderly people are they're easy prey to people that would do this because they don't have the ability to defend themselves that well. And a lot of times they don't even know it's happening. Elderly abuse isn't just physical, it can be emotional abuse, it can be stealing their medications, which happens way more than it should. I mean, it shouldn't happen at all. But, grandson stealing medication to get high or to sell for money or whatever, that's medication that's meant for the elderly person. So stealing those meds is a form of abuse. Um, the exact intent or the exact extent of elder abuse is not known for several reasons, including the following. Elder abuse is a problem that has been largely hidden from society. We just don't like talking about it. It's one of those uncomfortable things. I mean, even me delivering this part of the lecture sucks. The definition of abuse and neglect among the geriatric population varies. Because when we think of abuse, we think typically of either sexual abuse or physical abuse, and it's broader than that. Victims of elder abuse are often hesitant to report the problems to law enforcement agencies or human and social welfare personnel because they typically either A, they know who's doing it, they don't want to get him in trouble, it's like their grandson or something like that, and B, depending on what the abuse is, they may fear for their own independence, especially if it's, you know, their independence hinges on that person being there, but that person is abusing them. If they report it and that person gets removed, now they can't fully maintain their independence and they wind up in a nursing home. So there's a lot of reasons why a lot of this stuff just goes underreported. So you may wind up getting called into these scenes, and this is what you're going to see. But yeah, the elderly don't like to report abuse. Let me find myself. The abused person may feel traumatized by the situation, or be afraid that the abuser will punish him or her for reporting the abuse. Anybody watch Happy Gilmore? I mean, I know that movie was funny as hell, but the the scenes where where his mom or grandmother is in the nursing home, um, I've seen it in real life, and it sucks. And actually, for as funny as that movie is, I can't watch those scenes. I have to skip past the Ben Stiller scenes. The abused person may be frail and have multiple chronic medical conditions like dementia. Elder abuse occurs more often in women older than 75 years of age. The physical and emotional signs of abuse, such as rape, spouse beating, and nutritional deprivation, are often overlooked or not accurately identified because they're signs that we would typically see in an elderly person. Um, so a lot of times we overlook the fact that they may be intentional. Take note of the environment and conditions the patient lives in. Um, if you see any soft tissue injuries, it can't be explained by the person's lifestyle and physical condition. These are signs that there may be some abuse there. You should suspect abuse when answering answers to questions about what caused the injury or concealed or avoid it. If they don't want to tell you, um, which is kind of a stereotypical thing, I know. It's like, oh, I fell down the stairs and I don't want to talk about it. That's that's a sign of abuse in all ages. And then suspect abuse when you are given unbelievable answers. Information that may be important in assessing possible abuse includes the following: caregiver apathy. If the person taking care of the elderly just doesn't seem to give a shit about the injuries, that's a problem. They should care. I mean, I you know I talk about this stuff and I think about it being somebody in my family or somebody I know or even somebody I don't know, and it still has an effect on me. If the person that's taking care of your patient doesn't have any kind of apathy, they have this. I'm sorry, they don't have any sympathy or empathy. If they're apathetic to it, that's a major red flag. Repeated visits to the ER, history of being accident prone. Maybe they're not really all that accident prone. Soft tissue injuries, unbelievable, vague, or inconsistent explanation of injuries. Psychosomatic complaints, chronic pain without medical explanation, self destructive behavior, eating and sleep disorders, depression, and substance abuse or sexual abuse history. Many patients who are being abused are so afraid of retribution that they make false statements to protect either to protect the person who's doing it, or they think it's bad now and it could be much worse if they say something, so they're probably not going to say anything at all. Repeated abuse can lead to a high risk of death, and a preventive measure in reducing additional maltreatment of the patient is identification of the abuse. And in 50 out of 50 states, um, we're mandatory reporters for abuse, and that's of all ages. Just like when we talked about it for children, it's the same for adults and elderly. Some signs of physical abuse. Injuries may be the result of acute or chronic abuses. It could be something that's been happening for a long time. So bruises on the buttocks and lower back, genitals, and inner thighs where you wouldn't normally get a bruise. It doesn't make sense to accidentally get something there. Cheeks or earlobes, neck, upper lip, inside of the mouth. Pressure bruises caused by the human hand may be identified by oval grab marks, pinch marks, or handprints. Human bites are typically inflicted on the upper extremities and can cause lacerations and infection. Inspect the patient's ears for indications of twisting, pulling, or pinching, and evidence of frequent blows to the outer ears. If you're suspecting of elderly abuse and you think that you see some damage around the ears, if you've got the little scope thing to do so, check out the eardrum. If they've been getting their ears boxed, a lot of times or not a lot of times, but they run the risk of having a perforated or a popped eardrum, and you can see it. Investigate multiple bruises in various stages of healing, just like any other age. Typical abuse from burns is caused by contact with cigarettes, matches, heated metal, forced immersion in hot liquids, chemicals, electrical power sources, and anything of that sort. Check for signs of neglect, such as a lack of hygiene, which, you know, that one's a little iffy because a lot of elderly patients themselves may just choose not to take care of themselves. But um, this is a sign of neglect as well, especially if they're not able to do it. So if they rely on somebody else and it's not being done, that's a sign of neglect. So lack of hygiene, poor dental hygiene, poor temperature regulation, lack of reasonable amenities in the home, and regard injuries to the genitals or rectum to be sexual abuse in any patient. Geriatric patients with altered mental status may never be able to report it. So keep that in mind. They may not have reported it just because they just weren't able to do so. And many women do not report cases of sexual abuse because of the shame and the pressure to remain silent. Again, it could be any number of reasons. It could be protection of who it is that's doing it. It could be fear of reprisal and it being worse. Um, we don't know, but just understand that a lot of times with when it comes to kids, they don't know that they can report. When it comes to elderly, they usually choose not to. All right, so that's going to be it for the chapter, and that is it for your lectures. Kind of a bittersweet moment. I've liked talking with y'all. I'm looking forward to the boot camp though, because I get to hang out with you face to face. But I'm gonna go ahead and give you your pin, and this is it. The next time we meet will be in person. Um, your pin for the night is going to be B as in Bravo, C as in Charlie, the number 35, and the letter G is in geriatric. So BC35G. And my pleasure, man. Hey, it's been an honor getting to talk to y'all. I've really enjoyed this class. 35 chapters almost. I know we skipped a couple, but y'all have been great. I've had some classes where nobody ever interacts at all, and it sucks. It's very hard to teach that way. So I've really enjoyed it, and I'm looking forward to seeing you guys at the boot camp and getting y'all on your way to getting your patches. Appreciate it, and y'all have a great night. Any questions? Oh, before I let you guys go, because this was asked earlier, your module exam, your module, what is this, module 5? Your module exam is a all-encompassing final. So don't go into that thinking that it's only going to have the last 3 chapters. You're going to get questions all the way back to chapter 1, which is kind of good. It's only 50 questions. You're not going to get all 50 questions from like pediatrics and geriatrics. So it'll be watered down, but it'll be a good test of where you stand for the overall thing. If you get into this test and you bomb all the cardiology questions, um, take that for what it's worth. Start focusing on that as we get you ready for your registry, because that test will also be all inclusive. Does it hold weight for the whole class or so it's just the module. It's just like any other module. And you try to get that 75 or above. I'll give you guys 2 attempts. If you don't pass the first time, You can take it again. But yeah, I made it this way so that you can kind of get a, I'll say due date being boot camp. All right. There's no more lectures. I don't have to worry about y'all keeping up with the class at this point. So have it done by boot camp. For you, Winston, Pascagoula is the 11th through the 15th. In fact, we'll set that due date. We'll set the 10th class wide, even though some boot camps are happening later. We'll set the due date to the 10th. That way, I'm guaranteed to have your final grades in by the time we meet in person. If you don't get the 75, yeah, just text me and I'll reset you. Pascagoula and Abita are the same week. So I'm going to have a different, one of our paramedic instructors will be doing the Pascagoula, I'm sorry, doing the Abita location. I will be at the Pascagoula location because it's their first time hosting it. And I want to be there to make sure everything goes right. Unfortunately, we won't be at the brewery. That would be awesome. Alexandria is the next week, starting on the 18th. Yeah, your ride-alongs are pretty well set. I've gotten in touch with all the ambulances. We don't have any that are kicking back or anything like that, so you should be set. Now, you have to have your uniforms and your picture IDs, student IDs for the ride-alongs, which we'll get the pictures done for that at the first day of the boot camp. So it should come in pretty quick. Yeah, you're good for Pafford. Pafford is ready to go for us. I just need to get them the rosters to know who's going to be riding and when, which we'll get the dates from you at the boot camps. From here on out, with the exception of the boot camps, your ride-alongs, you actually tell us when you can ride, and we make sure that the ambulances can get you on those days. So the exact length of the course at this point kind of depends on you. When we'll know the dates. There won't be any ER rotations for the basics. Advanced EMT and paramedic get the ERs. I put all those ER hours into your ambulance so that you get more time actually on the trucks doing what you're going to do. Because basics in the ER, you want to just sit standing along the wall. You don't get anything out of it. So don't worry about the ER. If you don't have your shirt, that's okay. You don't need it for boot camp. You just need it for the ambulance. So go ahead and order it soon if you haven't already. How much time do we have to put into ride-alongs? 48 hours. So 4 12-hour shifts, and you're done. Oof, that sucks. Okay, so yeah, um, it's a third party that does the shirts, and if they're that backed up, then definitely don't wait for your shirts. If you got to have them to ride. So if you don't have your shirt, that's okay. Just understand that I can't put you on a truck until you have your complete uniform. So they may cause a little bit of a lag before you can actually start doing your 48 hours. The shirts are ordered on our website. If you go to aresmedsolutions.com, you're going to see, in fact, let me pull it up. Hold on. I'll tell you exactly where it's at. Do 2 12-hour shifts from EMR crossover. When did you do them? I don't mind if you ride for AMR as well. Wait a minute. I misread that. 2 12 hours from EMR. No, unfortunately not. You're going to start fresh. I thought you said AMR. All right. To get your shirts, if you go to our website and click on shop on the far right, apparel and uniform store. Just get your polo from there. You can get your pants. You guys on the fire department, your regular fire department pants are fine, and your boots are fine, and all that. But for those of you that don't have those, you can buy 511 pants from Academy. Would be all right, or whatever other brand you want. But they need to be like tactical BDU style pants. dark colored pants, and your polo needs to be black. Any other questions?
Hey, Robert, I have one that's bugging me from a different class, and I have yet to get it answered.
What you got?
Not a different class, a different chapter. One of the questions on the test, and I probably can't tell exactly, but I'm pretty close. Arrive on scene as an MBA female, still inside the vehicle, unconscious, no signs of life. What is your next step? And of course, me, we're stressed, ABCs, ABCs, ABCs. Is she breathing? That was the wrong answer. The right answer was C-spine immobilization. It's like, huh? Why would I do that? I mean, if I go ahead and climb in the car with her and maintain C-spine, she ain't breathing, she's dead.
Right.
I totally disagreed with that answer. I'm like, that's not right.
That could be a bogus question. Can you do me a favor? Text me the chapter that question was in. I'll go back and check it. And
Okay.
yeah, if it's a bogus question, I'll give everybody credit that missed it.
I'm actually in Alabama, out of state, but I wrote it down on my notebook I used because it bothered me so much. It's like, that is so not right. Okay.
Okay. Yeah,
But I'll get it to you.
let me know when you see it. Katina, your shirts you don't necessarily need for boot camp. You only need them for your ride-alongs. So for the boot camp itself, just wear some functional clothes. I'm not going to say you have to be professional. You don't have to be in a uniform. Dress casually. Just understand that you're going to have to bend, stoop, pick up, that kind of thing. So closed-toe shoes for protection of your toes, and I shouldn't have to say this, but short mini skirts are probably not a good idea to wear to boot camp. I've actually had that happen. Yes, I'll put it into the Facebook group. So keep an eye on Facebook where the boot camps will be. I'll give the addresses. All right, I'm going to stop the recording now. Again, for you guys that watch this recording, it has been a pleasure. And I look forward to seeing you.